Good morning. It is 10 o'clock on Monday, the 28th of November 2022. This is the last formal meeting of the calendar year, so for those members of committee and officers that found the mince pies, I'm glad you've helped yourselves. And for anyone that hasn't yet availed themselves, please feel free. So on that note, welcome to our guests. Some are virtual and some will be in the chamber with us. So welcome to the meeting of Staffordshire's Health and Care Overview and Scrutiny Committee. I am your chair, County Councillor Jeremy Pert. And before we start the agenda proper, I'd just like to make a couple of introductory remarks, if I may, please. First of all, I'm sure committee would like to extend its thanks to Prem Singh for his expert guidance as chair of the Staffordshire and Stoke-on-Trent Integrated Care System. To get the massive machinery within the £2.5 billion local NHS system up and running so seamlessly is a huge achievement. So thank you, Prem, and can we wish you well in your retirement as of the 16th of December 2022. Can I also congratulate the Staffordshire and Stoke-on-Trent Integrated Care System for making it to the shortlist, one of 7, for the Best Integrated Care System of the Year at the recent Health Service Journal Awards. Quite a significant achievement. Can I also add my congratulations to the many that have been received to North Staff's Combined Healthcare Trust for not only being shortlisted as one of 9 trusts for the Trust of the Year at the same awards, the Health Service Journal Awards, but also to have won the Best Trust in the year. This is the main award of the night, so this is a tremendous achievement for North Staff's combined. Congratulations. I have asked for the latest monitoring report on hydrogen sulphide to be circulated around committee members, so apologies to those county council members who will have already had the report, but given committee's concerns last year, I did at least want to make sure that this was still on the radar in relation to the health impacts to residents in the north of the county. Finally, I understand that NHS England have a meeting scheduled with the ICS Commissioners to review the revised business case for inpatient services in South East Staffordshire for people experiencing severe mental illness at the end of the month. This item is scheduled to come back to committee early in the new year. So, let's move on to today's agenda. Can I remind committee that today's meeting is being recorded? And for those who want to watch it back today, the recording can be found, not just watch it back today, but anyone who wants to watch it back, the recording can be found on the County Council's website. The meeting is also being beamed live for people to be involved and will cut off 20 seconds after the equipment has stopped. All voting committee members are in person, and there is a variety of in-person and virtual attendances as our guests. And so, to our guests, can I ask our guests to accept that members have read and digested the papers provided, and as a result, restrict their comments to 5 or 10 minutes, depending on the item, subject to the conversation on dashboards, where I think we might just want to get a bit more of a hands-on feel for that. And second of all, can we focus on the tangible outcomes for the residents of Staffordshire? Let's use the data and experience that we have to sharpen the quality of debate and scrutiny so that we can provide assurance and reassurance that things within the health and care system and in public health in Staffordshire are going in the right direction that we'd like to see for our residents. So, the agenda proper. That brings me to item number 1, apologies.
Good morning, Chairman. I've received apologies from Lynn Hingley, Patricia Ackroyd, Councillor Atkins and Councillor Abrahams. Councillor Philip Atkins.
Thank you, and thank you for that clarity. 2, declarations of interest. Do we have any declarations of interest relevant to this morning's agenda? Councillor Anne Edgeler.
Thank you, Chair. Good morning, everyone. Yes, I am Partner Governor from the County Council and Midland Partnership Foundation Trust.
Thank you. Councillor Bernard Peters.
Local Authority appointed Governor at UHDB.
Thank you. Appreciate both of those. Okay, no other declarations. Let's move on to... actually, before we do that, can I just confirm for the minutes that we are quorate? Thank you. We are. That is good news. Item number 3, minutes. Can we, actually, before we approve the minutes from Monday, the 17th of October, I would just like to note from the minutes on page 6 that there is a workforce strategy coming forward in social care that is referenced in the minutes, and that's coming forward in February or March next year. I cannot remember if we did ask for that to come back to committee, because I'm sure we'll be interested, but if we didn't, I'm sure that was a mistake or omission at the time. So can I suggest that that becomes the 3rd point on the top of the minutes on item on page 7? Are we happy with that as an approach? I'm getting a few nods. Yep. Okay, so if we can add that as a forward agenda item, but also as point 3, I'd be grateful, please. So can I ask if the minutes, with that exception, are a true record of the meeting? Yeah, plenty of nods and plenty of affirmations, so let's move on. I'm reliably informed that all actions have been followed up on and all information received to date has been circulated. Can I just comment in terms of the Ockenden report item? I note that the Samuel Johnson and the County Hospital freestanding maternity birthing units remain closed on safe staffing grounds, but equally note that UH&M have recruited a significant number of midwives, I think 17, and they continue their recruitment to get to full complement. I also note the publication of the East Kent midwifery report that was after last meeting, which is relevant to that item as well. And if members have a spare moment over Christmas, that might be a useful document to read. So on to item number 4. And that's the Public Health Performance Dashboard. Claire, I know that we refer to you as the Interim Assistant Director. Actually, I'm looking in the wrong place, aren't I? I don't know why. I know we refer to you as the Interim Director, but actually it's the Assistant Director, isn't it? So apologies that we got that wrong, and please don't take anything into that. Would the Cabinet Member like to say a few words first? I usually get told if I don't ask the Cabinet Member.
Thank you very much, Chairman. Councillor Northcote will start off with a brief introduction. I may or may not add a few comments, but Councillor Northcote will do that. Sorry.
Good morning, councillors. Good morning, Chairman. Delighted to introduce this item, just to give it a little bit of an introduction and background. During the pandemic of COVID-19, it highlighted how much accurate information can be used in terms of tackling performance and decision making to keep the council up to date. This dashboard has come about from that. The aim of this dashboard is to build upon the success that we gained during the learning experience from COVID-19 dashboards, and it provides data, that is the aim, and information for our commission services, major change programmes, and it follows a request made by yourself, Chairman, and the Scrutiny Committee to build a platform for public health and the prevention data. This work aligns basically with the principles of public health and prevention of the delivery plan of 2022-27, including our aim to understand the impact with a continuous cycle of improvement going forward as Staffordshire County Council. It will allow us to assess progress against the outcomes outlined in the Council's Health and Care Strategic Delivery Plan 2022-26. Now, the aim of this public health prevention dashboard is to minimise individual data and insight requests and inquiries. It's helped to reduce that information stream into a more condensed and efficient and accurate presentation form. Now, today we're hoping to gain your input, and members also sitting here today, of how you want to shape this. Your input is obviously very valuable in how we're going to shape this, along with the brief skeleton that we provided today in the report. It's organised according to public health outcomes that we've been very keen to follow, and it particularly influences the determinants of health to increase our healthy lifestyle and health expectancy, particularly with health improvement and life expectancy. It's hoped to develop and facilitate access to the community and capacity to help older and vulnerable adults to also remain healthy and independent chair, and to optimise activity and the quality of public health services, which also include, as you know, drugs and alcohol, healthy lifestyles and sexual health. So I'll move it on to the Assistant Director of Public Health, who will help to give the presentation some fleshing out in terms of its material. Thank you, Mr. Chairman.
Thank you. My colleague Lucy's actually going to introduce the item. She and Louise next to me have put all the hard work in, so I don't want to steal their thunder, so if that's okay, I'm going to hand over to Lucy.
Thank you, Claire. So just to get a bit of a nod to Louise, who's sitting beside Claire as well, who is the brains behind the Power BI platform that we've used. So just a quick introduction. My name is Lucy Hegarty. I am a Senior Commissioning Manager in the Public Health and Prevention team, and with my colleagues we've been building the dashboard. So just to add to what Paul has laid out there, that we get a wide wealth of data from our commission services and from the change programmes that we're working on within public health. So the initial challenge was around, okay, well, which are the key bits of information and data that will tell a bit of a story about the success and challenges within our services. So that's what we've done. We've gone away and tried to drill it down to the most useful and specific information, tried to align it to health and care outcomes, and the effectiveness of the programme, but also we've looked at the quality and the integrity of the data as well, because obviously some of the data is of better quality than others. So I'm going to share my screen, and it did work 15 minutes ago, so fingers crossed it'll work now. Yes, it's worked. Brilliant. That's a good start. So this is the Public Health and Prevention dashboard. You'll see here that there's a whole host of information about how to use it. The immunisation and screening bit, that's the top one there, I know that you can't really see it very well on the big screen. Hopefully those of you who are virtual may be able to see it a bit clearer. And as I drill down, it will be a bit bigger. The immunisation and screening one is a phase 2, but you'll see there that there's some information there around the determinants of health. So we have life expectancy, health improvement and warmer homes. There's something there around the community capacity, developing and facilitating access to community capacity to help older and vulnerable adults to remain healthy and independent. And there we've got some information around our supportive communities programme. And then the last public health outcome there around optimising activity and quality of public health services, that relates specifically to these ones here, which is drugs and alcohol, healthy lifestyles and sexual health. So I'm not going to go into each one of those today because obviously there's a whole range of things, but what I am going to do is show you a little bit about how it works. And the intention is then that those who need it and want it will be given access to the dashboard so you can go in and interrogate the data a little bit further for yourself. Had a bit of a conversation with the chair a few minutes ago about doing a follow-up session once you've had a chance to look at and observe the information to actually drill down a little bit further into some of that information. So if you were to click on the life expectancy, just to give you a bit of a view as to the kind of things that you'll see, this takes you directly to the Public Health Outcomes Framework, which is a national document, and there you'll be able to see how Staffordshire, which is here, compares to much of many of our colleagues in this region, in the West Midlands region, and you can interrogate that one and play with that one at will. That obviously that's very much the kind of the background information, the information that sits behind all of that. What we've tried to do with that information is drill down a little bit further in terms of our specific services. So if I go to sexual health, which is I commission sexual health, so I've picked that one because it's something that I'll be able to more easily explain to you when it comes up. The way that it's been designed, you'll see that there's some tabs along the bottom, which hopefully you can see. And each tab follows a pattern. So it's the same for the healthy lifestyles and for drugs and alcohol. where you'll have an initial slide, which what we've done there is picked out some key benchmarks that we think highlight some of the challenges that we have within that area. So for sexual health, the first one is around new sexually transmitted infection diagnosis within Staffordshire, and you'll see the green line there is Staffordshire. The pink line is West Midlands, and then the black line is England, so you can see how we compare on that. If you want to focus, that's much clearer for you to see in the room. You can actually focus on that. It will give you a lot more detail, a lot clearer detail. Again, the other two we've picked within this one is syphilis and gonorrhea rates within Staffordshire. And the reason we've picked those is because they're a really good indication of the sexual health of the population, those particular sexually transmitted infections. So again, you can see that we've tried to pick indicators that show you, give you a bit of a picture as to what's going on as a whole within the county. What we've done then alongside that, on the second tab along, so down at the bottom there, is we've started to drill down a little bit more into more detail as to what the services are actually providing. So just as a bit of an indication, you can see that obviously the impact of COVID there in terms of the drop in face-to-face access, an increase in online access, just as an example. What I wanted to show you, though, is that you can drill down further into these. So if I was to pick 2022 as an example, because obviously this year isn't finished, you can drill down into the quarters and then even further into the months, so you can see what's actually happening in terms of that face-to-face access and again the online access. There's further information as well around what each of those mean, so you can drill down even further, and like I did before, there's also this focus mode. So there is some information on that initial screen, if I just go back, around how to use each of these drill down and navigation buttons, so you can have a look on that initial screen as to how to do it. So if I just go back to that sexual health one, for example. So you can see there something around what's going on in the service and then that service quality. So this is done in the same way for sexual health, drugs and alcohol, and the lifestyle services. Supportive communities is slightly different in that this is a change programme rather than a commissioned service, but again we've stuck to a similar sort of format. So this initial sheet shows you here the case for change, if you like. So the need there, because obviously we've got a much higher and growing ageing population. So you can hover over each of these and it'll tell you a little bit more detail about what that is. And again, you can drill down further into further detail to give you more information around what the detail behind each of those indicators are. And then again, just like with the commissioned services, you can then drill down further into some of the actual pieces of work that are being done. So this was around the digital access to our resources, for example, staffordshire.gov.uk and Staffordshire Connects. And the Community Help Point programme, which is a new programme within the Supportive Communities programme around having help points in each of the localities. So again, you can see much more detail within that. Lastly, the Warmer Homes programme is again slightly different in that it is it's not a commissioned service, but it is a service that is provided as a change programme. So again, a similar sort of idea that you've got your benchmarks on the front page, and then you can drill down into much more detail in terms of the actual what's going on within the service. And as you'll see on this one, there's locality data as well. There's varying degrees of locality data amongst the different areas. Because, for example, sexual health, it's a very different. It's done on a county-wide basis. It's much more difficult to drill down that detail into that local data. It is something that is possible, but it's not something that we've asked for in that level of detail. Whereas Warmer Homes, this example, actually you can have a look. You can drill down into each of these and see exactly what's going on in each of the localities. So that's the dashboard as it sits at the moment. It is phase 1 at the moment. So this is the first iteration of what data we can use and how we can illustrate that to you. We are about to get started on phase 2. As I mentioned before, immunisation and screening is one that we'd really like to be able to give you more relevant and regular detail about. The other area is clinical risk, particularly again around our commission services and the level of risk there. And we'll also be looking at some other notable areas within the public health and prevention portfolio. So the next steps, the access will be provided to members of the Scrutiny Committee by invitation. So once we've got the names, we can get those organised fairly quickly. And I would ask you to have a look and a bit of a play with it. You can't break it, so please do have a look and a play and see what you think. The intention is that it will make it much easier for you to get the kind of data that you might have to ask for on an individual basis. It will, I'm sure, pose questions, but as I said at the beginning, there may be a more fruitful way of us providing you with some of the answers around that on a subject-by-subject basis. And then please review it, let us know what you think, let us know if there's any things that you think are missing that you'd like. Obviously, I'll refer back to what I mentioned at the beginning around the quality and the integrity of the data, so we will try and respond to any queries or thoughts that you might have about where we move, but actually we do need to recognise that obviously it's only as good as the data that goes into it, so we have to be careful about the quality of the data that we put in it. We wouldn't put anything in it unless it was of quality. So that's me. If there's any questions, myself and Claire and Louise will aim to answer them.
Thank you, Lucy. Thank you also, Paul. I think there are two issues from what I can work out. One is how to use the system, and obviously we've had a very quick canter through that, and frankly, a bit like, the first time you use your laptop or a computer, it's a bit of an alien world, and certainly the speed we've done that this morning, I think is probably bewildering for some members, me included. So hence the suggestion to organise a longer session for members which will record on Teams to actually see how the system works and maybe play with it yourselves at the same stage so that you feel comfortable with it. So I think that's the first thing. And the second is, what is the data telling us? And what the data is telling us is proposed that we will invite Lucy and her colleagues, Claire and Lucy and Louise and her colleagues back on a regular basis to see how we are trending on specific areas. And so today's session wasn't really about what is the data telling us. It was more about this is the building of the data. So with that sort of lengthy preamble, asking anyone to break a system, Keith is always very good at breaking systems. So let's move to Keith.
Thank you, Chair. I don't think I try and break systems. I just try and make comment on them to try and make them a little bit more usable. Yeah, I mean, obviously it's early days, so please take my comments in relation to that. Obviously, we've seen data dashboards as well from primary care area and things like that as well. And I think they've got to be interchangeable. They've got to be able to be so we can consider what's happening in terms of people having access, as well as how the services are being delivered and how the improvements are being made. So I think that's where I hope you're trying to get to. Is that the idea overall? Brilliant. I do think that, like with children's services and what's been happening with that, it is district-based. I think you called it, in the end, locality data. What we really want is district data, I think. So from an internal perspective, I think we need to have, that's what this committee is about, really. It's having that element of information that we feel as though we can make comment on in these meetings, have some positive sort of look at where we might be going with these areas, and then being able to try and help you improve those services for all our residents. I think that's really what I'm saying to you at the moment. And I realise the quality of the data isn't there at the moment, so all I can really ask at this stage would be for you to maybe consider how that might work in the future. So I realise this is going to be an ongoing process. So as I say, I'm trying to be supportive. As I said, supportive communities out there. So that was one thing. But this breakdown to district, and then also the way that the communities and the services you're providing through the communities and prescription and all the rest of it, social prescription, all the other things like that. Again, linking back to primary care. I think that's an important area where we can keep people in the community as healthy as possible for as long as possible before they have to go in and start using regular services within your healthcare services. Does that make sense? So I think if we can find that and focus on that and then base that on the districts, I would think that that would be a great objective. Does that help at all?
Lucy, before you come back in, can I invite the Cabinet Member just to say a few words, and then if you follow immediately afterwards, please.
Yes, I'll leave Lucy to clarify localities and districts. I think one of the things this dashboard starts to do is not only identify activity, the activity of the contracts and arrangements that we have, but actually how that impacts via the outputs, the outcomes, because that's the key thing. There's quite a significant sum of money, it's, you know, in the region of 40 million that we have to invest in public health. And one of the things that I and the team are very keen on is that the services that are commissioned actually do deliver. And it's not just the activity, it's the outcome. And some of that is quite difficult because some of it, you know, weight management is down to changing people's behaviours. So I don't underestimate how difficult it is, but we have to have a sharper focus so that if you commission a service and it's not working, it's not delivering, the trends are not going in the right way, well, you try something different. And I think we have to be bold enough to do that. In terms of supportive communities, that's another area where it's quite new in a way. We're promoting this, and it's what are the outcomes? In many ways, the longer term outcome is that we have fewer and fewer people as a percentage, particularly the older population, heavily reliant on social care and NHS care. That's got to be an outcome measure. Now, through public health, there is a joint project in East Staffordshire with the Primary Care Network on social prescribing and what they call the Joy app. One of the longer term outcomes of that is that hopefully people can be supported in the community without the great range of medications that they're on, particularly those with depression, because actually antidepressants are not always the best way of dealing with it, but it's that building and supporting of communities to actually help people be more resilient and be able to maintain a healthy life actually in the community without being so heavily reliant on health and social care. I know I've said it, and you've probably heard me say it at full council meeting. The way we've done things in the past with an ageing population is not sustainable. So we have to have a different focus. This dashboard will enable you to drill down, and actually it'll give you a pointer as to the questions you've got to ask us.
Thanks, Julia. Just to come back on the question around the districts, I think where that is available, then that's certainly something we can look at in a lot more detail. I just wanted to manage expectations on that a little bit, though, because for some of the data, actually the district level information isn't helpful, it isn't useful. So if I take sexual health, because I understand sexual health better than some of the other areas, if you take HIV data, for example, you could be talking about 1 or 2 people in a district, which obviously is very, very specific and actually can be quite intrusive potentially if we drill down to that level of detail. So I just wanted to manage that expectation a little bit, that where possible, yes, district level information can be considered, but it may not be available for everything within that.
Lucy, can you just pick up also on data integrity? I think there was a sort of a suggestion within what Keith originally talked about that about whether the data was accurate.
So we've really carefully considered which data we put into the dashboard for that reason. So the Commission services and also the Supportive Communities Programme and the Warmer Homes Programme do gather huge amounts of data. And that was the very first thing that we did between myself, Louise, Claire and others in the team, is to drill down and say actually which are the bits of data that will actually really tell a story accurately. Because actually we were really concerned about that as well. So there are bits of data that we're frequently questioning as to its integrity. Now that doesn't mean that there won't be little quirks, little issues occasionally, and I guess it's for yourselves and others to question what goes on behind the scenes on those. And actually, as commissioners, we usually know the reason behind it, or if we don't, we certainly should. So hopefully that answers your question.
Thank you. Keith.
Yeah, my comments really were more to do with trying to help districts in the way that they work at the moment with the family improvement boards at district level, the children's services at district concept, all these other areas, and I think primary healthcare also has some areas and some analysis at district as well. It's if you can join that together with your primary care, other services, that will then mean that then the way this committee works, which is on a district basis as well to some extent, having the outlying committees in each of the districts, I'm just concerned that if we don't say that now, or we don't have that in as an objective as we go forward, and I'm not talking about specific services if they're down to a few hundred, I'm talking about the general trend in those districts to help us as members to try and support all those other services out there through the communities and everything else, which I'm sure the other cabinet members are aware of as well. So it links back to all that work as well. That was all. Thank you.
The fingertips data, the information that I showed you initially, I've not got it up now, but the information that's available nationally actually does drill down quite low down. So actually, you'll be able to, once you get into that, you'll be able to interrogate that. But I guess I would suggest you have a good play with it and see if you can, find out the information that you need from it first. And if you're not finding that information, then yeah, please do come back to us.
Just following up that, and then I'll bring in Mike. Just on that, we had a discussion about where the observatory sat with one view of the truth. Maybe you could just reflect that back, because I think it probably does link in part to where Keith's going, I think.
My team is the observatory team, and we've helped design the dashboard, so we're all tied in one single vision, the truth.
Thank you, Louise. So to be clear, I think what you're saying is that the observatory is still there, there's still a commitment to the observatory, and that still provides local district data in terms of what's happening both at a Stafford, national, regional, Staffordshire and local level.
Yes.
Thank you. I'm going to move on to Mike Wilcox, please.
Thank you, Chair. Just to build on what Councillor Jessel said, about the outcomes being really important in any of the sort of work that we're doing. In relation to the data that's captured, I assume some health professionals will then be able to look at those areas where there is need or there is a risk, etc., so that more resource can go into that area in order to bring that forward. Will that then come forward as some sort of action plan to senior leadership who can then monitor that and put it forward? And will that at some stage, Mr Chairman, come back for us to review? And I'd be interested to know what the period of time for that is in relation to doing that, please.
Claire.
Thank you. So the dashboard is as much a tool for the internal public health team and the Director of Health and Care as it is for this group and any kind of other colleagues who might find it useful. So it's very much about how we can internally have that day-to-day oversight of the data, make sure we're really clear on our commission services and the performance and sort of outcomes of those services, as well as some of those national data sets that we need to keep an eye on. So it's not that we're not doing that already, but it's sort of consolidating that into one place. And as Lucy said, commissioners and those people responsible for those services will know day to day sort of what's happening in terms of performance and delivery and any of those hiccups that might impact on that performance. So absolutely what we're doing is using this dashboard to inform our sort of annual delivery plan and our team-specific action plans to shape either how we commission services, I mean, that kind of cycle tends to be over several years, so it's not something that we would change overnight, for example, but it at least allows us to then work with providers to unpick any of those issues and understand what the sort of contextual factors might be. And then if we need to think about a change to our commissioning model in the longer term, we can build that in. So yeah, absolutely, it's part of what we're doing in terms of informing our day-to-day and our annual action plans.
Mike, anything further? Okay. Jill Hood. Thanks, Jill. So that brings me on to Janice.
Thank you very much, Chair. If I could just emphasise the need for the locality information. I appreciated what you said about warmer homes only, and I think when we have opportunity to have a look at it, that may help give me a bit more of an informed choice. I did think about moving a bit closer, but I still don't think it would have helped me to see any of that. Definitely support the premise. I can very much advocate the use of the data to look at targeting interventions and the outcomes especially. That's what we're looking at. I think it might be helpful just to have a little bit more detail on how you're actually collecting the data, because obviously the data is the fundamental component of it all, and how representative that is. Is it reflecting the entirety of the county, or are there some pockets that aren't necessarily being captured? And then my other question is to do with the subjects that have been identified so far. Is it the data that's leading the subjects that have been focused on? You mentioned specifically on there about sexual health. And if there's other sort of topics and themes that might be added to that when we have an opportunity to have a look at it. Thank you.
Lucy.
Yeah, certainly in phase 2, I think we felt that it was a good point to sort of draw a line under phase 1 and share it with people for thoughts and comments. And obviously we've shared it with Julia and Paul, and the feeling was it would be useful to share it here as well before we embark on phase 2. So certainly any thoughts and comments. Again, just to kind of manage expectations, obviously we want to make sure the quality is kept high and the integrity of the data is kept high. So just because it's suggested that we want to do it doesn't necessarily mean it will happen, but it's certainly something that we'd appreciate feedback and would like to continue to develop it in a way that makes sense for both us as a public health and prevention team, like Claire said, to continue to use, but also for yourselves to get that higher quality of data. I think the other thing, just coming back on something that Julia said previously, is sometimes with some of our programs it's really hard to get outcomes data, so actually good quality output data can go quite a long way as well. So actually that's also the other aspect of it, that actually if we've got the right sort of output data that we know is contributing to those outcomes, that can be a useful data point as well.
Can I just bring in Claire, please?
Thank you. Just to add to that point, you specifically asked about how we'd sort of identified the topics, I guess, to cover in terms of the dashboard. So the idea is that it's aligned to the health and care delivery plan for our directorate, which in turn is aligned to the strategic plan for the county council, so that we've got that clear sort of golden thread throughout that kind of strategic framework. That said, as Lucy says, it's very much about where we can access the rigorous and robust and kind of validated data. So we have a whole plethora of information from our commission services in terms of performance and lots of output data, some of which is sort of useful to include, others probably more flawed, therefore we probably wouldn't want to have it on there. And then there's also the national data sets, which are very much more the sort of validated, cleansed data tools that have been through whole sort of rigorous processes, and that would include things like the life expectancy data. So it's a combination of both. As Lucy said, we've sort of worked for many months to try and scrutinise the range of data we have access to make sure it's A, aligned to our sort of strategic direction, and B, is the most robust data we can include on there, with probably a few caveats. If you've got specific questions about the source of any particular data set, we can certainly share that with you, but some of it will just be that comes through our sort of commissioned providers.
Okay, thanks, Janice. Moving on to Bernard Peters.
Thank you. Good morning. I'm from East Staffordshire, and I just wondered if you could give me a view in terms of the reach to people who maybe English isn't their first language. How is that going to fit into the model? And secondly, just a general question, if I may. I've listened very intently to what's been said, and I just wonder how much weight you've given to delivering this model in the context of the current recession, the pressures that the public are encountering in terms of the cost of energy and being able to eat regularly. Pre-pandemic model, as it were. So is there a factor there to make sure that you're taking that element on board?
Lucy.
Yeah, so in terms of the ethnic makeup of the people who use our services, we do have that data within our commission services. We haven't pulled that through into the dashboard, not at this stage anyway. That is something that is considered within our own contractual discussions with our providers. But as I say, it doesn't feature on the dashboard at present. In terms of the cost of living crisis, again, we've focused at the moment, like Claire was suggesting, very much on the public health outcomes and in reflecting back to you some of the high quality data that we've got within the services and the change programs that we've got. So again, there's nothing specific around cost of living on there. That's not to say it can't be something that we consider in the future, but again, temper expectations. We'd have to consider whether that data was available and of quality and telling us anything of use. That makes sense.
Thank you. Can I bring in Clara?
Thank you. So just to add to that as well, so just to be clear, the intention isn't to have this as a public-facing dashboard for a number of reasons, partly because there's sort of commercial data on there effectively in terms of our commission providers, but also because it's potentially more sort of damaging or risky to have that kind of data available without the context and without the sort of opportunity to have that direct conversation with the public, as we'll be able to with you guys when you've had a chance to look at it. So it's very much for our internal use, and then obviously we can share specific bits of information as we do whenever we feel that's appropriate with the sort of contextual information behind that. And in terms of the sort of cost of living challenges, as Lucy said, in terms of our wider programmes of work, we absolutely will always look at how we can support those who are in greatest need. So we've got a big piece of work at the moment around sort of support over winter in terms of warm homes and keeping people active and fuel poverty, and that links very much to things like the warm homes data that you've seen in here. So there's various bits of work happening, and health inequalities as a sort of principle and a focus always underpins everything that we do.
Bernard?
Thank you for that clarification. I fully understand the model that you're describing, looking inwards, not outwards. But what I want to do is make sure as this starts to mature and develop that I understand it. It'll be one heck of a multi-headed beast, perhaps, and there will be bits in there, and I'll be looking at the bits for East Staffordshire and Burton. And I just wanted to try and tease that out of the way you're going. That's all. Thank you.
Can I just also add to that? I mean, we had a discussion before committee. I think there is a need to integrate the data backwards and forwards into the observatory so that there is one source for the data, because then it picks up Bernard's point about, all those demographics, and, we shouldn't be classified by our illnesses, we should be classified by who we are. And actually, what we see is the interventions, not necessarily the wider piece. So I do think there is potentially something which is worth looking at there, which I think is what Bernard's touching on. Can I just take Chair's licence before bringing in Phil? I know this isn't particularly part of the agenda, but you referenced warmer homes, and it's nice to see Stafford Borough at the top of the list, but leading the pack. But that wasn't my point. My point was probably, does someone want, out of the group we have in front of us today, to give some advice for winter, given we know what's happening in terms of that cost of living squeeze? It would seem to be, and I know it's not related to data, but you referenced specifically warmer homes here. Does anyone want to give any public health suggestions for those in our communities based on the winter ahead? Julia.
Can I just say that my understanding is central government will be doing a nationwide advertising campaign to give people advice how they can keep warm, how they can reduce their energy usage and obviously the costs. And of course, as we know, money is already being passed to people to reduce the sting of increased energy bills. But I understand within the next week or so there'll be a national campaign to advise people on that. I think it's a matter of, in many respects, using common sense. And dare I say, quite a lot of older people, like me, I was brought up with vests and liberty bodices. We're used to being quite practical. And I think it's not being too proud to put on, it's fairly simple. I've turned my heating down, and we have what we call a granny blanket, which are these wonderful fleecy blankets to put over your knees in the evening. We're a bit like the Queen, I don't want to make light of it, but I think there is a lot of common sense out there. But I do understand that the central government is now going to have a nationwide advertising campaign to raise those other things that we can all do to ensure that we remain healthy, that we still have ventilation in our homes. There is a danger both from condensation and lack of fresh air. We still need to do that, but actually still keep ourselves as comfortable as we can and reducing our bills. I don't know whether Claire wants to add anything.
Claire does. I was going to say, I thought you were going to say don't suffer in silence and please talk to the relevant public sector authorities. But you make a really fundamental point on ventilation, mould and damp, and the stories from Rochdale will resonate in all of our ears. Claire.
Thank you, Chair. So specifically on kind of advice heading into winter, we produced a leaflet which does exactly that really, in terms of referencing some of the common sense measures that people will often know, but perhaps just reminding them of that, but also how to access support locally if people feel they need it. So things like the Warmer Homes programme and the Beat the Cold charity that works alongside them, how to make sure you've accessed benefits that you might be entitled to, strategies to try and reduce loneliness and isolation, which are issues year-round, not just throughout winter, but can get particularly acute during winter, and sort of promotion of some of those stay well messages around things like COVID and seasonal flu vaccination. So it's about 5 or 6 key messages. They will be going out to targeted households. There's been quite a complex piece of data triangulation to look at which specific sort of households and geographies across the county would likely be most receptive to those messages, but we're also pushing them out through community venues and numerous other routes. So I can certainly circulate the PDF of that leaflet if that would be useful, but that is going out and about in the next week, I believe.
Thank you. And obviously you're laying down a challenge to each and every one of us to take back to our districts and boroughs to challenge them to share that information. Thank you. Useful discussion. Apologies, it wasn't about data, but I thought it was relevant. Phil.
Firstly, I have to dispute that Councillor Jessel isn't even remotely old enough for a granny blanket. And should rethink her strategy on that one. And secondly, again, like Councillor Jessel, I'm trying not to be flippant, but in this chamber we often contribute to the reducing the heating bills, don't we? And I think we've done that successfully again this morning. I'm not being flippant. It's not the warmest place, is it? Yes, there is a question in there somewhere. Right, I'm moving on, Mr. Chairman. We are currently measuring COVID. And at what stage do we stop measuring COVID? And is this flexible enough to say, actually, flu is also long-term issues, and are we flexible enough to move and be fairly agile to start measuring other things? And I appreciate this is very long-term data, but flu has been with us since forever, and I wonder whether, and we have some really bad flu years, and I wonder whether at some stage we don't start looking at that and looking at some of the wider variants that we could look at. And the reason I ask that is because we've moved to COVID, haven't we? COVID didn't exist like 4 years ago, and we moved to COVID. And are we flexible enough to think if something else comes along, or flu becomes a bigger issue, or it's currently a long-term issue, we're flexible enough to move to that? Thank you, Mr. Chairman.
Thank you. I think Lucy is going to take this.
Yeah, so one of the first things we're going to be doing in the next iteration of the dashboard is actually putting some of the what we call health protection data on there, which will include immunisation data, so flu vaccines as well as at the moment at least the COVID information. And we'll be looking at, in the same way we've looked for the other areas, we'll be looking at the best data to give you in terms of the picture as to the scale of the issue and some of the things that we are doing within the public health team around resolving that. So that's a watch this space one, I think.
Thank you, Mr. Chairman. Thank you.
Can I make a suggestion also that under item 6, you might want to ask the question in terms of an update in terms of how COVID is looking in Staffordshire at this moment, and that may be something you might want just to ask. Jill Hood.
Thank you, Chairman. You're talking about a campaign by central government about how we're going to warm our homes, and it's my opinion that we're aiming this at residents who have nothing. So how do they cut down on nothing? It's very, very worrying. My division is Stone Urban, proposed, sort of expected to be an affluent area. And I'm meeting residents all the time who just don't know which way to go. Do they buy food or do they heat their home? Let's hope central government isn't going to do the campaign on television because many of them will have no electricity. My main point was about the mental health services, and I was wondering about the dashboard, whether there's a facility for us to individually input data, as we are at the coalface with our residents. And I do feel that the mental health services offered in my division are chaotic, they're not effective, and the quality is extremely low. And I've been saying this over and over for people who've got an alcohol problem. What's on offer to them is abysmal. And my heart goes out to them because it's sporadic and there's no continuity. And again, and I ask, how are you measuring the outcome of success for those people with drug and alcohol problems? To me, that there's no proof anywhere that there is a success, and they're so limited. Thank you, Chairman.
Okay, Claire.
Thank you. So in terms of mental health services, that's not something that we have responsibility for within public health, so that's probably a conversation to have with our NHS colleagues, or they will absolutely be part of that conversation, and we are working very closely across the system to develop the system-wide mental health strategy. So obviously we have a role in terms of public mental health, which tends to be more towards sort of prevention, early intervention, keeping people mentally well and sort of ensuring that resilience to deal with life's ups and downs. So we can absolutely have a look at whether there's anything around that could be incorporated. The second point around, I guess you were referring to co-occurring mental ill health and substance misuse, which is an age-old, very complex, very tricky sort of area to work within, and we're very aware of that, as are our colleagues in the NHS. It's never a simple one to work through. However, we've got some really exciting pieces of work now kind of in there, not complete infancy, but not fully mature yet, so that are exactly looking at those issues in terms of multiple complex needs, and it's about bringing together teams from the NHS, so people with a mental health specialism, professionals who work in that field, with drug and alcohol specialists to support people. To support people in the round, I guess, so as a whole person, looking at all of their needs in one go, as opposed to segmenting specific sort of issues or topics just because it suits how we commission our services. So that's absolutely something we're aware of and working with our colleagues to grow and develop. So I'm happy to have a separate conversation with you about that if it'd be useful.
So just, can I preface my comments just before bringing you back in, Jill? I think today's item is the principle of a dashboard for public health, identifying the outcomes and the trends. That was the purpose of today's item. I do apologise for taking it slightly off track with my last question, but it just seemed important to do so. The whole purpose of talking about dashboards that talk to each other and have one version of the truth allows some integration of that data. And certainly I know that the integrated care system is working on dashboards, because that's also come in front of this committee as well, and that's certainly the intention to get that view. I do accept that there is a huge complex nature of some of the coexisting conditions that some people, some vulnerable people in our communities do have. Jill, I'll bring you back in if it sort of sticks to the principle of thank you. Mike Wilcox.
Thank you, Chair. This might drip in my interpretation, but looking at the dashboard and the areas that you're covering, I don't see anywhere mention of children's services or children being part. Are they sort of altogether part of the main health and wellbeing service, or is that a separate strand altogether, Chair?
Feels like a Claire one, or sorry, Lucy.
Want me to go? So we're actually part of two separate directorates within the county council, so it's a slightly quirky sort of arrangement. And the children's public health sort of day-to-day responsibility, although it falls under the Director of Public Health in terms of the statutory duties, sits with Natasha Moody in the Children's Directorate, and they already had their own dashboard developed. So for that reason, it's not part of this. But we do obviously on a day-to-day basis work very closely with the teams, particularly for some of the all-age programmes like the Better Health Staffordshire obesity work. So that's the reason it's not specifically referenced within this dashboard. I believe there is an existing dashboard for children's.
Useful, thanks. And they are diarised to come to committee in February. Thomas J.
Thank you very much, Chair. Granted, we only had a very quick glance at some of the tables, but there was one summary table that showed the red, amber and green and compared us to different areas. And what struck me, there was two particular areas that had quite a lot of green. They weren't Staffordshire. Is there any work being done to see what they're doing that's made them green in so many areas where we're not? Any learning from them?
Lucy.
Yeah, I think that's something that we do as commissioners anyway. It's something that's a regular. As I mentioned before, the data that we look at is far more than the information that's been presented through the dashboard, and certainly how we do compared to our statistical neighbours, and also how we do within the West Midlands is a key thing. The other thing, again, I can only talk for my own services, but we're part of networks as well. So for sexual health, we're part of the sexual health network for the West Midlands. So we do regularly have conversations with our colleagues in other local authority areas in the West Midlands to understand how we can help each other, share with each other, etc. So that's a regular part of the commissioning cycle.
Do you want to come back? Okay, before we move on to the next item, just let me ask one question if I can, please. There's a whole range of different indices and metrics which, you know, the professionals like yourselves work on day in, day out. So actually the complexity of the wide-ranging number of them and what they mean is not a problem. Maybe for people new to this area, it would be good to be able to identify which of the two or three we should start with and focus in on, and then, you know, as we increase our understanding on those, we start moving to other metrics as well. And it strikes me that healthy life expectancy is a good way of starting, because most things drive from there. What's your view? Claire?
I think you're right. That's a very useful starting point. However, we're not going to see a significant change in healthy life expectancy in the next 12 months, for example. So it comes with the sort of caveat that, you know, that trend will not shift for some time, and it obviously is hugely impacted by all of the contextual factors, both across Staffordshire, across the UK and the world. So we have to have it as a sort of baseline, and it's obviously an overarching ambition for us to increase healthy life expectancy in particular, in terms of the numbers of years people live in good health. However, we will then need to look at some of the other measures as sort of proxies, I guess, in terms of the direction of travel, and we can certainly make some recommendations. And actually, there isn't that many on the dashboard, so I think once you have a chance to have a look at it and sort of work through from the front page, it's very digestible, it's hopefully very easy to use, and shouldn't be too complex. So I don't think it'll need too much filtering to make it a usable and useful tool, but we can absolutely make some recommendations if that would help.
Thank you. And I think what you're saying is it's not that difficult. Just dive in and it's digestible. So there are two recommendations in front of us. One was to review and feedback on the dashboard. I think we've done that over the last hour and discuss potential improvements as part of the iterative process. Can I suggest there is probably three other things that we should look at in terms of recommendations. One is to circulate the log-on details so that members can dive in and do something practical from this session. Second of all, or additionally, that we will diarise for committee time to look at some of the trends, because we've not really talked about the trends, we've talked about a system. And then thirdly, to look at a training session in the new year, just so that when we come to log on, we know what we're doing. Is that fair? Getting a few nods? Yep. Okay, so I think that brings this item to a close. I think it's really positive because I wanted to see data for a long, long time. I think this does do that. It does demonstrate the direction of travel. So thank you for providing the system and the surety that, that the data does do that. And thank you for offering to come back and help guide us through that. So Julia, Paul, thank you. Claire, Lucy and Louise, thank you for the work you're doing. And you're welcome to stay, you're welcome to go. Otherwise, we will thank you and we'll move on to Anne Edgeler. Now, two things as we move on. One is apologies to Anne in the work that she's been facilitating, that we haven't been able to bring this back to committee sooner. This was work done in June, so apologies for that. There is clearly a link between the two items, this item and the previous one. Can I hand over to you, Anne Edgeler?
Thank you very much, Chairman. Good morning, everyone. I think I speak on behalf of all members of this committee in saying I'm really pleased that this workshop took place on the 21st of June this year. More needs to be done between districts and the County Council to encompass the health of all our citizens throughout Staffordshire. We need to work together to help alleviate as much as we can the problems that are currently taking place within our health services. This report captures the main message from the Scrutiny workshop held this year. I'm pleased to report that everyone who took part in the session found it fast-paced and there was a good vibe in the room. The main message from the discussion tables were captured on flip charts and form the base of the report today. I hope everyone has an opportunity to read the report in full. As with most scrutiny sessions, there were more matters raised for officers and partners to think about. Claire and her team have had an opportunity to look at these matters and added some further context into the report. In summary, our job today is to consider the evidence in the report, draw our conclusions about what we can influence and make some recommendations. Claire and members of our team are in the meeting to provide further context in response to questions. Can I now invite members, please, to start the discussion? Thank you.
Thank you, Anne, and thank you for the work that you've led on this. Much appreciative of that, and thank you for changing the conversation. Claire, is there anything you want to add to Anne's opening comments, or are you happy that we move into questions in terms of what do we do next? I think that's the question, isn't it?
Yeah, I'm happy to move on to the discussion. Thank you.
Okay, thank you. So I'm not seeing anyone indicate yet, so let me start then. Two things. On page 20 under recommendation 1, it talks about localities in terms of districts and boroughs, planning, licensing, leisure. I wonder whether it should include housing, given that housing is a really key determinator of health. We've just spent a long time talking about warm homes and warmer homes, and it does strike me that housing is a really key link in there. If you haven't got stable employment and stable housing, then often you haven't got a base to start from, is probably the point I'm trying to make. And under 3, identify a named district lead and be the champion. And, you know, that district lead could be, I guess, a councillor or an officer or both. And the paper is silent on that. Maybe you could confirm for us. Claire.
Thank you. I think you're absolutely right. It could be any or all of those things. I think the point of writing the paper in this way was very much to leave it open for members to shape and sort of ensure there was ownership of the recommendations and the actions. The team and I could have put in some very clear recommendations for things we think should absolutely happen, but that wouldn't necessarily be a reflection of the views in this room. And I think that's the important part of this, is it shouldn't be just what we say should happen or think should happen. It's very much what's relevant to each district and borough, and your own priorities and sort of needs of your population. In terms of a champion, I guess that led on from a conversation at the session around, you know, sort of how do we take this to the next level? How do we ensure that momentum is maintained and that it stays a high-profile piece of work and underpins everything that we do? Because I think that's the key really with the sort of health in all policies approach. It doesn't have to necessarily be new pieces of work. It's more about how we think differently and reflect on the impact of everything that we do in terms of the health and well-being of our population, both in terms of positive and negative impact. So hopefully this aligns very well to a conversation that I've also been having with your chief executives at the CEO's group, and I took a paper on health inequalities about 3 weeks ago, and there was a similar conversation about having a director level champion or advocate within each of the districts and boroughs at an officer level, similar to the economic prosperity director group that already exists. So as you say, Chair, it could either be a sort of member sponsor and a senior officer lead, perhaps with some support underneath that as well, or one of those, or both. So I think it's open to the group to sort of determine really what would be best fit.
Does anyone have any thoughts in terms of just following up what Claire's said rather than more questions? Is it on this subject, Keith? Keith?
Exactly on this subject. I wasn't at the workshop, but reading through the notes and everything else, some of the comments I've written down is that this won't work without officer support. So that was my gut reaction to everything that has been proposed today, and also in terms of what we've just been discussing in terms of getting outputs and then driving ideas through at district level. And myself, Barbara and Charlotte, we don't even know necessarily in terms of who's in charge of it at cabinet level, let alone officer level, within our district. And I think that we've got to do quite a lot of work on that. And I do think that we can't deliver necessarily what we would like to try and deliver. And that includes children's services and many other services that are linked at district level as well. This is overlap. And because I'm on do the children's services and the family improvement board and all the rest of it, you know, I can see where the blockages are. And if there's no understanding or any discussion at district level in terms of trying to deliver anything, even if it's through the county, how can we go forward in terms of trying to deliver anything like this? And I think that's the key point that I picked up on. So that was exactly what I was saying. We need to have some way of being able to develop those links and being able to develop what we're trying to do through for the outputs of this workshop as well, which I'm sure Anne's been working on, and it includes mental health as well as everything else. So I do think there is some key piece of work here that we need to do. Thank you.
Interesting. I'll just bring in Anne in a minute, but you say that work that we need to do. Actually, I'm not convinced that it's the we need to do. I think the districts need to do to determine who their lead is, but rather than the health committee.
From our perspective, Chairman, sorry to interrupt. From our perspective, it's what we need to do to drive change within the districts in some areas. Not all districts are the same; they're all slightly different. But it's understanding how we can deliver what we'd like to try and do through this workshop at district level. That's the point I'm trying to make. Yeah,
and I guess my gut feeling is that maybe the local scrutiny committees should be asking the right questions so that the districts determine the right answer for them, because every district is different. And I also just reflect that some authorities are heavily member-led and other authorities are more officer-led. And we've got to be careful not to force feed and force fit something that potentially alienates people from this. I would also encourage that we keep this as a public health discussion, because we have no remit in this committee to look after family improvement boards and the likes. Let me bring in Anne Edgeler, and then I'll just sense check whether Janice is on the same subject. Yes, okay, Anne.
Thank you very much, Chairman. I mean, my thoughts really are, I think it should be a member from this committee, actually, that's on district, you know, to be able to bring it all together and keep it all encompassed in one area, because I think we on this committee have got more understanding of what's happening out there than probably some of the officers or chief execs or, you know. So I really feel that it should be focus-led on this committee. And I'll come back again, Chair, when everybody else...
Thank you. Janice.
Yeah, thank you. I did attend the session, and I thought it was an extremely insightful exercise. There is some argument about how sometimes we can be quite parochial in our areas that we are representing, and this is a county-wide event. But at the same time, what I was really quite aware of, or made more aware of, was the role that parishes have. So we're putting a lot of information onto districts, but actually for the areas that I represent, then parishes are probably one of the most instrumental communication methods of being able to get to really the residents in those rural areas especially. And so for me, actually, it's not just about the district side, it's about how we bring in the parishes. Now, the part that I was alluding to was in some parts of the county that isn't relevant at all. And how there isn't necessarily a one-size-fits-all approach here, and that we do have to think about specifically the areas that we are representing in an effort to bring everybody together, not just to bring out our own areas, but actually the fact that there isn't this universal part for me actually at the moment. There are the parishes and districts as well as boroughs. Thank you.
Thank you, Janice. Paul, I think you're on the same subject.
Thanks, Mr. Chairman. It may be helpful for members that I share something that's going on at district level at the moment. We understand that when you mention health to districts, there's a tendency that officers tend to think, oh, this is too huge to manage. How the hell are we going to be able to do it? Pardon my language. What we're doing at Newcastle at the moment with the help of Claire's team is we're looking at how do we embed health into policies. And to do that, we've chosen the local plan process in terms of looking at obesity and weight gain and how that can be affected at a district level, at a locality level, in terms of the grouping and massing of scale of, for example, fast food outlets near schools, for example, looking at possible zoning. But we realised we were taking this approach because health is such a massive area. How do we actually grasp it to make that change, that difference? And to list everything is probably too overwhelming. So to be able to make some tangible difference to change the culture that exists at the district at the moment, if we can get policies embedded with health outcomes, that is a step forward in a follow-on work that can happen after that, because without those little acorns of growth, we're not going to be able to get an angle into this. We need to get that foothold. Other things can go and piggyback off in terms of going forward to change policies. And also the, as you said, Keith, you know, that the district side is very dependent on members and their relationships that they have with their cabinet team. And I think this is an opportunity for a good many of the members in this council that are dual hatters to get that understanding at district level to how they could probably embed health aspirations with their policies, but that obviously needs an understanding with both officers and the cabinet members' approval. So hopefully in Newcastle we're going to use this template to be rolled out to other districts to help them in terms of embedding policies in the future. I thought that might be helpful, Jeff.
Thank you. And obviously what you're talking about, Paul, is about having the discussion, which then raises the awareness and then creates the actions. Can I bring in Phil Hewitt? Thanks for being so patient.
Thank you. Can I just congratulate Councillor Northcote on delivering everything that I was just about to say. So it saved us a few words. Councillor Northcote was absolutely on the nail. He got it spot on. And I've never said that before, Councillor Northcote, have I? And,
thank you.
Thank you. If I'm off piece, Mr. Chairman, please interrupt me. So this is totally underpinned by the Francis report. It's as simple as that. And unless we get this right, then we're not compliant with the Francis report. So sadly, I was on holiday, or joyously, I was on holiday during this, so I didn't come to this event, and I'm really sorry I didn't, because the Francis report underpins all of the relationship between the county and its scrutiny. Ultimately, this scrutiny committee scrutinises the health, and then on top of that, in simplistic terms, the districts feed into that, don't they? And that's what Francis said was absolutely vitally important that happened. So Paul's right. In Cannock, we've tried to do the same. We tried to, in the last 3 or 4 years, tried to make members really understand what our role is. Certainly, you know, we've had some issues with social media where our scrutiny committee's been challenged, and the level of inaccuracy because people didn't understand what that scrutiny committee was doing. Certainly, my colleague to my right has worked really hard on making sure that Cannock gets it right, exactly as Paul Northcote has just said it. But unless we get this right, we're not complying with what Francis says. So if Francis came back tomorrow, excuse me saying this, Mr. Chairman, time and time again, anecdotally, districts do not turn up to this meeting. This is their opportunity to scrutinise, and they don't come, Mr. Chairman, and it's not right. Time and time again, districts don't come. It's absolutely vital that they come, because it is a Staffordshire-wide scrutiny meeting. As you can see, I get slightly ill-tempered about this, that they don't understand. Because if Francis came back, Mr. Chairman, we might have to explain where some of those districts was. So on top of that, my one question to Councillor Edgela, can we do this again? Because I don't think this battle is won by one meeting in June. I think this battle is won by 2 and 3 meetings a year, Anne. And I really would like to see this again, to really pull in the districts and say, this is how we should work together. This is specifically your role, and that's how you feed into county scrutiny. I presume I wasn't off-piste, Mr. Chairman, was that?
So, a useful thank you, and move the discussion further forward as always. So can I just come back on a couple of things? 3. First of all, we are refreshing the terms of reference between districts and boroughs and the county. That work is 9/10 the way there, and I just have to do a bit more work on it before we take it back to officers, and then we will bring it back here. And I think that provides the clarity that we work to today. I don't think that if Francis was to come back to this committee and see how it operates, that we're missing a trick. But maybe there are some missing people who should be here more regularly. The second point I'd make is the agenda for this committee is member-led. You know, it is something that where members have a concern, or we have a concern about the risk to individuals within our communities across Staffordshire, then we bring that to this committee, and if there is a sufficient groundswell, then it comes on the agenda, as has been the case for as long as I remember. And the final one is, rather than necessarily doing the healthy communities again between this committee, maybe the appropriate thing to do is to take it down to district and boroughs, and for there to be a commitment from public health to go and deliver those to help engage that conversation. Can I just bring in Annie Edgler and then yeah.
Thank you for that, Councillor Hewitt. And that question, I think we've discussed this at the beginning of the meeting with Councillor Pert, the chairman. So, and he suggested at that time, you know, about taking it down to district level. So probably that answers your question. And thank you.
Phil, just do we want to bring in Claire? Do you want to say anything in terms of maybe doing some work down at districts and boroughs?
Yeah, certainly. I think you're right. It's not a one conversation kind of topic, is it? It's hugely important and kind of ubiquitous and something that we need to keep talking about. I think almost to sort of drip feed the information and to win over sort of people in terms of the value and importance of what we're trying to do. Part of that, I think, is demonstrating how it aligns to the existing sort of agenda and priorities of each of the districts and boroughs, whether that be through economic growth and prosperity, housing development, whatever that might be. And I think that was what we started with the session earlier in the year, and we can continue that certainly with specific sessions with each district and borough. And I guess what that would allow us to do as well is support members and officers in shaping a more tailored plan, I suppose, and commitment. As we've said, it's not a one-size-fits-all approach, although there will be certainly some areas of good practice and tools that I think we'll be able to share across each of the districts and boroughs. So, for example, with the work Councillor Northcote was just talking about in Newcastle around the saturation of hot food takeaways around schools and how we can tackle that through embedding health and wellbeing policy framework in the local plan. If we can get in really early when a local plan is being refreshed, that allows so much more flexibility and leverage actually in terms of how planning can impact on health and wellbeing throughout the life of that local plan. That kind of good practice could easily be replicated across all of the districts and boroughs if other areas are interested in doing something similar. So, similarly, in our team, we're developing a health impact assessment toolkit, which should be a useful kind of quick reference, off-the-shelf tool that people can utilise for any of the big sort of policy and strategy decisions that they're making to consider the impacts on health and wellbeing. And we can then support with anything more kind of long-term and any of the bigger decisions. So I think there will be some quick wins and some easy things we can share, and then there'll be a process of shaping a more localised sort of plan and commitment, I think.
Phil.
Thank you. Thank you for that answer. Thank you for your answer, Mr. Chairman. Can I just clarify things? There was zero criticism of this scrutiny committee. None at all. I think this scrutiny committee does an excellent job, and there was zero criticism. It's whether the wider boroughs engage is my challenge, shall we say.
Thank you. None taken either. And Angela.
Thank you very much, Chairman. Really, it's a question for you, Claire. You know, I read somewhere about diabetes bus. And are there any plans to roll this out, a diabetes bus going around Staffordshire and being able to pick the people up that probably suffering from diabetes but don't realise it? Because on a personal basis, I didn't realise how much diabetes can have such an impact on people's health and what they can suffer from because of it. You know, your main organs and everything within your body. So I just wondered if we can, or will that be being rolled out? Thank you.
Can you answer very briefly, because that's a long way off the process about what the district and boroughs are going to do? Just very briefly, please.
Not something I'm aware that we're implementing in Staffordshire, but again, that would likely be an NHS healthcare provision. Our role really is around identification of diabetes through sort of screening into our and referral into our prevention programme, which does actually work really, really well and has a really high level of referrals. So I can have a chat with you about that afterwards if that would be useful.
I think Councillor Edgell is also volunteering to be an ambassador for, not driving the bus, no. If she is, let me know to keep off the road. But to be an ambassador for the NHS on that, please. Do we have any further comments in terms of this report? So can I try and summarise where I think we are? What we're aiming to do is to embed in the districts and boroughs some of the discussion and some of the public health outcomes that we've talked about both in this report and in the dashboard before. Taking on board Janice's point about also needing to think about the role of parishes as well and making sure that that information trickles down. Maybe that's a requirement of district and borough councillors to take that to their parishes, given the sheer volume of them across the county. Also to have not just a senior officer lead, but a senior councillor lead. I think my suggestion is, should we get every district and borough to table this report at their next scrutiny committee to then say what are they going to do, if that scrutiny committee, as Councillor Northcote indicated, is already on the process, maybe they just reference the fact they're already on that process, on that journey, and just ahead of everyone else, and that's fine. But maybe the other bit is to extend an invitation to Claire and her team to come and talk about some of the local data and some of the local public health data that's in terms of what it tells them. There's a few recommendations in there. How comfortable do people feel we're taking this report and those recommendations to committee? Bernard.
May I just ask for a point of clarification, Chairman? As you know, I'm from East Staffordshire and Burton, and a lot of residents in Burton get their NHS care at Derby. Now, how does that model fit?
So, I mean, I think much of this is public health, which is being driven by the county-wide. So, notwithstanding the NHS point, I mean, this is county council delivered services in the main, notwithstanding Councillor Edgela's point about diabetes. Are we happy with those recommendations? And in which case, are the relevant contacts going to ensure this is on the agenda at a local level for your next committee meeting? Getting a few nods, that's good. Okay, thank you. I appreciate that. Is there any further comments before we give our thanks to Claire and to Anne Edgeler? No, in which case, thank you both for fighting the good fight on this one. I know it's been a while since June. Apologies it's taken us so long to get this back into the agenda. It is no reflection of the importance of the work or the quality of the work. So thank you for the members who've been engaged on this. Let's move on to the next item, which is... we're early for a change. I don't remember ever doing that. I might need to go and buy a lottery ticket. Primary care access. Chris, I think we're with you this morning. Welcome to you and Tracy Shewan.
Thank you, Chair, and welcome. Hello, everybody. I'm joined this morning by a colleague, Dr. Paddy Hannigan. Paddy will introduce himself, I'm sure, but Paddy's going to take us through some of the key drivers that we've outlined in our presentation. Paddy's only going to hand back to me. I'll then talk colleagues through the slides. I won't do that in detail because they've been in the pack, but just offer some supporting commentary, and then both Paddy and I are more than happy to field any questions that colleagues may have. So hopefully that's okay as a way forward. Paddy, if I could then please invite you just to talk through the key drivers, please.
Thanks, Chris. My name's Dr. Paddy Hannigan. I'm a GP in Stafford. I've been practicing Stafford for over 30 years now. I'm the clinical director for primary care for the ICS. Key drivers for current issues around access for general practice. I'd like to start by saying that last month in October in England, 36 million people went to their GP practice for an appointment. I say that because some of the sections of the media have reduced the discussion around accesses to simply saying, I can't get a GP appointment. We are getting through colossal volumes of appointments, over 300 million appointments in England last year. Locally, we're running hot. We're running at about 6% higher activity than we were in 2019. A number of reasons for that. We're included in that is the vaccine program. So we've done 2.8 million COVID vaccines in the last 2 years, 65% of those done in general practice. We've also managed a lot of the questions, queries, and issues coming up from the vaccination program. And another phenomenon at the moment is we're having to manage the significant number of patients on the backlogs for waiting lists for activity in other parts of the system. That probably is accounting for 2, 3, 4 patients per GP per day. Just managing either patients wanting to expedite their appointments on a waiting list or manage their conditions whilst waiting to be seen in secondary care. Against that, we've got a continuing problems with workforce. There was a target set many years ago of recruiting 5,000 extra GPs nationally, or sorry, in England. During that time, there's been actually a reduction in about 400 fully qualified GPs rather than an increase. The national response to that is to create a new workforce in general practice. And a new acronym called ARS, Additional Roles Reimbursement Scheme, a whole range of different professions now working within general practice, so pharmacists, physiotherapists, mental health workers, variety of roles, but hopefully building to about 26,000 additional roles supporting general practice by 2024. So of those 300 million appointments in general practice, only about 44% of them are actually done by GPs. there lies a problem in that we haven't particularly explained this well to the public, and so we tend again to reduce it to getting an appointment with a GP, and the complexity about that wider workforce and the necessity to find out why patients want to be seen and signposting them to the correct places is something we've probably not done particularly well. As well as that, we're also seeing this sort of continued pressure from on staff and practices from the ongoing sort of COVID infection. So a reasonably complex situation where we're seeing more patients. We have workforce pressures, particularly with GPs themselves. We've got a new model of care based around a wider workforce. And I think the complexity of that and the communication of that is something we're not doing particularly well. I'll hand over to Chris now just to take us through some slides.
Okay, thank you, Paddy. So I am assuming colleagues have got access to the slides in front of them, and in fact they have just appeared on my screen as well. So if we can just move to slide 3, please, which is the one with the three wheels. Thank you. So, colleagues, as Paddy says, the number of appointments we offer in the NHS locally is increased relative to 2019, and we continue to talk about 2019, of course, because that's pre-pandemic level. So it gives us the last kind of normal, in inverted commas, period for benchmarking. And as you can see, the vast majority of those appointments are now face-to-face. In fact, we offer more face-to-face appointments locally than the national picture. But we recognise there is some challenges. Paddy's outlined some of those in his update just a moment ago. And indeed, that's essentially encapsulated in the 3 wheels that you can see there. So this is data that's taken from the GP patient survey. It's what patients tell us about their experience of general practice. The third of the 3 wheels looks at how patients describe their experience of their GP practice. And generally speaking, that's pretty positive. 71% of people would either describe it as fairly good or very good, and you can see that's comparable with the national averages. But I think the challenge that we have, and which we recognise, is then encapsulated in the other 2 wheels, which essentially shows that whilst patients have got a positive view of their GP practice and their GP, their experience of accessing the practice and making an appointment is much less positive. So the numbers drop off. So it's about 49% would describe it as easy, and about 55% describe the process as good. And whilst they are comparable with the national averages, that's, you know, it obviously encapsulates the challenge that we've got. So next slide, please. I'm not going to dwell on these particularly, but I think the challenge we had back from colleagues last time was to get beyond the headlines, show where we've got some variation. So the next 2 slides, which is this one in terms of ease of getting through by phone, and then overall experience of practice, do show we've got a range of variation across Staffordshire and Stoke-on-Trent. There's 146 or so practices across our ICB area. There was a detail on the slide earlier that showed the CQC ratings of those, so 8 of which are rated outstanding, 129 good, but that's nonetheless to say that we do have some variation in some parts. And obviously, as a primary care team hosted by the ICB, we work with those practices to try and understand the reasons behind that variation and work with them, even nationally as part of national programmes or locally, to try and improve things. Telephony is an issue that's often quoted as being a particular challenge, and we have got investment available to practices to support a move-based to cloud-based telephony systems, which does offer a much better patient experience. It also gives the practice data in which they can then use to inform their own service provision. About 65%, so about 2/3 of practices have taken up that investment. We're working with the other third. There are some challenges. So practices are responsible for their own telephony systems under the National General Medical Services contract. That often means they're tied into contractual commitments, and we need to work through those in order to introduce new systems and processes. Next slide, please. So Paddy referenced some challenges around workforce, and you can see here that whilst we're on the national average, so we have about 5.7 whole-time equivalent GPs per 10,000 patients compared to the national average of 5.9, so a little bit below, but generally comparable. We have nonetheless seen a downward trajectory over recent months, and you can see that clearly in the top chart there. That is offset by the increase in the other roles offering direct patient care. So these are the ARRS roles that Paddy described earlier, which would be first contact physios, mental health support workers, clinical pharmacists, etc. We have also got a particular challenge around nursing, and nurses do carry quite a heavy workload in terms of general practice. So that is something that we are both cited on, concerned about, and we've got plans to address. And then next, and I think final slide, please. Yeah, so this is details around what are we doing about all the challenges that we have, some of which we've alluded to as we've gone through. I won't go through the detail of all of those different options. Colleagues will probably be glad to know. In terms of just some examples, we're obviously preparing for what we expect to be a difficult winter. We do have some winter surge capacity in place. So these are the respiratory hubs. So patients with coughs and colds will be seen in a timely manner, and that will avoid unnecessary presentation to A&E and demand on acute services. I think we referenced last time the National Accelerator Programme, so that's a 20-week programme for some of those practices that would be at the right-hand side of the variation, so that we can understand the challenges that they have and be able to bring forward solutions for those. And then we've got a range of workload initiatives to ensure that we make best use of the resource we've got and get the right patient in front of the right clinician, apologies, for the right condition. And that includes, on occasion, developing some services that can be delivered remotely, so blood pressure at home and pulse oximetry at home. So there's a range of services in there. I think we are braced for a difficult winter. It'd be wrong to say that anything else, and some of the challenges we have got are relatively deeply ingrained. But hopefully the information we've shared this morning is useful to colleagues. As I say, Paddy and I are happy to take questions and comments. Thank you, Chair.
Thank you, really useful. First time we've seen this data in this format, so thank you for that. Seems like a consistent theme. Let me bring in Phil Hewitt first, and then I'll bring in Charlotte.
I think I pressed it twice, Mr. Chairman, on and then off. Could I say that this data is very useful? Some of it it's quite challenging, isn't it? When you see some of the challenges in there, but all the same, that doesn't mean to say that we shouldn't receive the data. That's great. But the obvious questions are: how are we coping with COVID and flu? And one of the questions I asked earlier on was whether we move some of the data on some other data that we received, or whether we start looking more closely at flu. And certainly around the world, in places like that, we're aware that there are some really big challenges with flu. How are we doing with that? Are we managing with COVID? How is the uptake on the vaccinations? Just general questions on an update on that. That would be great. Thank you.
Thank you. Paddy, we're with you.
From a primary care perspective, our main thrust initially is around prevention, so the vaccination programme. So COVID vaccination programme ploughs on, where I think we've done 2.8 million vaccines in 2 years. Our uptake rate for the autumn booster programme is pretty good. It's about 63% of eligible cohorts. we're at the national or above national average across all of our cohorts. I think we were one of 2 ICSs in the region to be in that position, so we don't have any sort of cohorts where we're underperforming. Flu vaccination rates are comparable to last year. Last year we had an outturn in the I think it's about 83 to 85%, and that's the highest I've ever seen in a flu vaccination program, and we're looking similar to that at this point of this year's program. So prevention, I think we're doing as well as I would expect. I mean, obviously the impact with flu will be dependent on whether we see an outbreak, and particularly Australia had a very severe sudden outbreak of flu in their flu season, which is in our summer. And that has driven a lot of the sort of thinking around flu this year. We obviously see and monitor flu levels, and we also have the antiviral agents, which have actually last week became available to prescribe in primary care if we start to see flu. We never know what the impact is going to be until we're in it, really. So I think we've done as much as we can around prevention and planning. And the impact, obviously, we'll wait to see it. Traditionally is early spring that we see the potential for that. So it'll be that sort of post-Christmas period.
Thank you. Can I just bring in Tracy? Could you just talk about the disease burden in hospital? Just give us a sort of a temperature check in terms of, what is COVID or flu looking like in hospital? Sorry to put you on the spot.
Thank you, Chairman. It's not like you to put me on the spot at all, but there you go. So I think as we're looking at admissions in the hospital, as we looked at the data last week on people that are in hospital with COVID, the numbers aren't as significant as we've seen previously, and certainly in that intensive care, though I do think we are seeing that increase in the flu. So we're just starting to slowly see that. That's based on what I saw last week, but colleagues who were on the screen might even actually know better data. But yeah, we're starting to see people coming in with flu. I think children, Paddy, perhaps we're seeing quite a lot of problems in children. That seems to be where there's quite a lot of respiratory problems, and certainly across the sort of region we know that paediatrics has been quite challenged at the moment. So it's a kind of watch this space, a bit like as Paddy said, and if we can do anything to encourage people to get that flu vaccination, get that COVID vaccination, I think it's really important.
Appreciate that. Thank you. Chris.
Yeah, so just to supplement that, Chair, if I may. So the 7-day incidence rate for COVID is currently less than 100 per 100,000 population, which, relatively speaking, is pretty low. And the bed and ITU occupancy levels for patients with COVID is also on a downward trajectory. Beds occupied by patients who have flu, as Tracy says, is on the rise, but at the moment is has just got into double figures. So we've some way to go before we start seeing that being translated into real pressure.
Phil, do you want to come back?
Oh, only very briefly. Just to say thank you, because firstly, to see the vaccination levels running as high as they are is a huge relief to everybody, and that is fabulous. Secondly, the understanding of what happened in Australia, and we're there, we get it, we're waiting for it. That is fantastic, Mr. Chairman. So that was exactly the answer I wanted. Thank you, Paddy. Thank you.
Thank you. Charlotte Atkins.
First of all, thank you for doing the sensible thing, which is to have COVID vaccination boosters at Leek Hospital, rather than people queuing in the cold and wet for 2.5 hours at the fire station. I went along to the vaccination session and it went very well, very seamless. In fact, I took the opportunity to have mine done at the same time. But can you tell me what the arrangements are for having vaccinations at pharmacies? Because I know that some pharmacists have applied and have been rejected, despite the fact that they are in the centre of the most deprived part of Leek, right next to a community centre. And the second question I want to ask is about the general practice workforce, in particular in relation to nurses. There seems to be quite a dip in terms of nurses, and given what you said about the importance of nurses within general practice, what are we doing to try and to ensure that that nurse cohort within GP practices rises again?
So just before you answer this one, Paddy, a little bit the last question we'll take on COVID, because this is a paper specifically about primary care. But given it's asked, then we'll take that. And obviously, we don't want to be just focused on leak, please, because this is a county-wide scrutiny committee, and we must move away from just looking at individual areas. But over to you, Paddy.
We got it wrong in leak. We set up what we would describe as a mop-up clinic, which Charlotte referred to in advance of the main part of our program. So we were basically had far too many people attending for the type of clinic we were running, and that was just an organisational problem for us, because we hadn't spotted, because of the way that the data is constructed, we hadn't spotted that the main volume of COVID vaccination leak, which would be done by general practice, hadn't started yet, and so we had the very keen residents of Leek queuing in the rain in a way that we wouldn't want to encourage, and that was because we generally put our mop-up clinics after the main volume of local programs has started and taken a little bit of the heat out of the situation. The issue with pharmacy is that the process around pharmacies vaccinating is not controlled within the ICS. It's controlled regionally, and applications have to go through region. But we do get asked, particularly where we have areas that are under pressure in terms of lower uptake, or particularly challenging sort of geographies, rural areas, or challenged communities where we want to put in additional capacity, but we're restricted in the number of sites that we can put forward. We did actually have over 100 pharmacies wanting to vaccinate, but the supply chain for COVID vaccine is complex, and I won't go into the complexities of it, but regionally they have been restricting the number of pharmacies, and we've had to make a case, and we have done. We've got over 20 pharmacies vaccinating and supporting other elements of the program, but it's not within our gift. That's a regional issue. Moving on to the sort of nursing element of GP workforce, it is a concern. It's a concern nationally and locally. Practice nursing, it's all, but practice nursing doesn't seem to have the same career structure as other elements of nursing. Practice nurses come from a range of different training backgrounds. They're often trained by individual practices. There's a particular demographic bulge, in the same way we're seeing a sort of demographic bulge of retiring older GPs, where that's even more pronounced in the nursing workforce. We have an entire workforce program around supporting all these elements of the workforce. So we have programs around recruiting and retaining GPs. We have similar programs around nursing and all of those additional roles. It's a really active program, but there are challenges, and as you can imagine, we're also competing with all other elements of the system in terms of the particular group. So we're working hard to try and recruit, retain both national and local programs, but it is an issue.
I mean, if
sorry, can I bring in Chris, please? Just wants to add to the answer.
Yeah, if I may, thank you, Chair. So it is a requirement for each ICS to have a people plan. So I think it would be fair to say, if we rolled the clock back a few years, we wouldn't have as much visibility on the challenge that we expect to have over the next 5-10 years, which, as Paddy says, is linked to the particular demographic around that particular workforce. So I think we know it's an issue, but at least we're cited on it, and through the ICS people plan, we've got a range of initiatives to address it. I think the Chancellor in his autumn statement also made reference to more work to do on NHS workforce modelling and forecasting. So no doubt, as that autumn statement translates into national policy, we'll be asked to revisit that as well.
Thank you. Back with you, Charlotte.
Yeah, well, it is good to see that the government has finally recognised that we do have to have a workforce plan. after many years of demanding it. But my concern is that given the pressures on GP practices, and the fact that you said that GP practice nurses come from a range of different backgrounds, what added incentive are you, or added effort are you putting into recruiting those nurses? Because it seems to me that GP practices will crumble if you don't have that range of additional professionals within the practice, because clearly it's not sustainable, the sort of numbers that are going to GP practices, if you don't have a fully staffed GP practice.
So just on that, my understanding is that the NHS People Plan is either published or about to be published. Is that the case? And then maybe pick up the second point that Charlotte was making. Chris, you're on mute, I think.
Apologies, Chair. So as an ICS, we are required to have an ICS people plan. We do have a version of that people plan. I'm sure if colleagues wanted to see it, we could share it. As I say, we are expecting further updates in terms of national requirements, and we'll obviously respond to those in due course. I think there is a challenge in general practice, which, as I say, there's about 144 of those across Staffordshire and Stoke-on-Trent. Generally speaking, they have traditionally worked as individual practices. I think with the advent of primary care networks, with the advent of the ICS, more and more we are providing support to practices to understand some of the issues that they face collectively rather than individually, and therefore we're able to bring forward more resilient solutions to help practices stay in services going forward. So it addresses some of the risks that Councillor Atkins references. Paddy may know more on the detail, but I think that's just kind of general position that we are supporting practices much more than we ever have done previously, I think.
Thank you. Do you want to add anything, Paddy?
It would require me to go into quite a lot of detail because the workforce plans are sort of multi-layered, really, in terms of the training, the recruitment, the retention, the sort of professional networking that people working in small practices, in individual professions working in small practices need sort of networking and local support and mentoring. So we've got a sort of multi-layered approach to all elements of that, and that sits in the primary care element or primary care workforce plan, which is an element of the system people plan, and there is a whole organizational structure behind that running through our primary care team up into the ICS people sort of planning and committees supporting that.
Thank you. I would like to move on, but I just, in doing so, would note that it's clearly part of committee's agenda going forwards to continue to look at that wider people plan, both locally and within social care. So can I bring in Mike Wilcox, please?
Thank you, Chairman. Clearly, your slides show that there are some practices that are doing much better than others. Are there any key learning points or any good practices that could be shared across the piece so that you can bring others up to their sort of standards? And in regard to those that require improvement, what sort of ongoing work is being done to make those or to get those up to the standard required by the public?
I think, as Chris has already sort of alluded to, we want to try and sort of build a more what we call a universal offer to citizens, really, around what to expect from primary care. The CCG's ran a programme which has now been running for 3 to 4 years called the Universal Offer, and it was originally set up with the idea or on the premise that any citizen of Staffordshire and Stoke-on-Trent could expect the same range of services from general practice, and that's been running, and we've done a process of mapping all of the different services that are available and ensuring that all residents have access to the same range. we want to move that on, and we're developing a new primary care strategy, and we want to talk about the universal experience. We want patients' experience of general practice to be similar, and as the two slides we've pulled out showed you, that isn't the case at the moment. So part of that will be how we take the learning from the best and try and support the people who are the practices who are more challenged, and try and get a more uniform experience. Where we'd like to go is in terms of universal outcomes, where any resident in Staffordshire can expect the same outcomes from their healthcare. So this sort of idea of universality and gives us the focus really in terms of that learning environment, taking what works well and trying to use it to support the practices that are more challenged. We have a primary care team, and much of their work has for several years has been doing this. We've been particularly focused on those CQC ratings, and wherever practice requires improvement, we have a supporting general practice team who will go in and offer tailored analysis and support in terms of that sort of process of leveling up and getting that universality in experience. But I think it'll probably be a key focus of our strategy in terms of trying to build that similar experience. And it's also part of that sort of population health management approach of using the data to be really clear, where the variability is, and then to focus on how we reduce the variability.
Chris.
And just to build on that, we didn't go through it in the interest of time, but the final slide within the slide deck we've shared talks about our continued development of the primary care strategy linked to the Fuller report, which colleagues may know is a national report published by Dr. Claire Fuller, which sets out 4 key areas of how primary care needs to develop over the next few years. But as part of that, we've developed a kind of 360-degree feedback monitoring report that looks in detail at individual practices, and some of the summary of the variation we've shown is kind of linked to that, but it does give us a pretty granular level of insight into the performance and the issues that are impacting on individual practices, so that we're able to work with those in the way that Paddy describes and the mechanisms that Paddy describes.
Thank you. I note that Mike's happy with that. Just let me ask one question off the back of it, though. When will you have the universal offer in a bit more granular detail so that we could offer some input to it, please?
The universal offer of services, it was a CCG program, so it already exists in its description of what services that covers, and we could bring that back or supply it in terms of the range of services that we would expect to be provided to all patients. And we've done it's a rather large and complex piece of work, because we have lots of historical services and we have historical anomalies, and we've been trying to sort of gradually reduce those. But we can describe that in some detail. The universal experience is a concept we're building, and we'll hopefully build that in, and we're going through a process of engagement with our practices in the development of the strategy, and we expect that to happen between now and the end of March, when the system needs to produce its five-year plan, and we'd want to use that to inform the development of that plan.
Thank you, that's useful. It sounds like we need to diarise something for committee before the end of March, by the sounds of things. Yeah, thank you.
Yeah.
Let me bring on Keith.
Thank you, Chair. On your ongoing plans, I see that you are looking at evening surgeries, and you've got other promotional leaflets there and everything else going out. Can I just emphasise the fact that I do like to see this? It's something, as someone who works during the week, I've had to cancel my flu jab 3 times because of work coming up, and so therefore I'm still not protected at the moment, and that evening sessions or weekend sessions, which is in fact the one I'm going to try and do this weekend with my own practice. I do think that that's something that you need to work on harder. I don't know whether that's possible or not, but if you are really concerned about children, and particularly at schools and things like that, and parents taking their children to have flu jabs and all the rest of it, if you're not going to cover it in the school timetable or anything like that, then this is the area of work that I think will take a lot of weight off the problems of emergency care at times. particularly during the winter months. So if you could maybe look at that as a way forward to try and reduce levels. I don't know whether you feel the same way as I do on that front, but certainly you keep going on about equal access. Now, if you're working and you're not retired and you don't have that time off, then this is the time then most people who work, who probably don't feel as though they need to have to take the time off work but still feel a bit crook or they're worried about something, the only time they can access is evenings and weekends. And yet that's the time that seems to be the most inappropriate for access to GP practices. Finally, I'd just like to make a comment in terms of volunteers, part-time workers. You've had the retained firefighter concept as well that is in the fire service. Is there not something we can do about job creation or some sort of different types of jobs where nurses and others could maybe come back just on a part-time basis to help with this concept of evening opening and part-time openings at various times to be able to cover people who work? I hope I've made my comments in a constructive manner, Chair. So it'd be interesting to see what they say when they come back. Thank you.
Paddy, we're with you.
Sort of two broad points I'd make. One is there are a number of services available for sort of evenings and weekends. So a national program called Extended Access, which actually Stafford, we piloted one of those schemes in Southwest Staffordshire 4 or 5 years ago, but it's continued to run, and the latest version of Extended Access started in October, and so every PCN offers evening appointments and Saturday and some Sunday access. I actually work doing that, some of those extended access sessions, and it's every time I do a session, somebody comes in and said, I never knew about this. So whilst we offer it, we do manage to keep it a secret. And I think that's one of the themes, is that healthcare is incredibly complex, and one of the things we need to probably do as an ICS is try and reduce the complexity so that patients are much clearer about how to access the right service in the right place. And Chris, on the second from last slide, in the centre of that was this concept. It's remarkably difficult for patients to navigate the system and end up in the right place. Some research done a number of years ago showed that just over 25% of GP appointments, the patient might have had their problem resolved more appropriately by somebody else or in some other way. So it suggests that there's a quarter of our GP appointments being utilised that could be available for stuff that GPs and only GPs can manage, which would solve our access problem in an instant. Equally, the various elements of our urgent and emergency care pathway. So we've got overlapping services with 111, out of hours, general practice, A&Es, and various other bits in between. It's remarkably difficult for patients to know exactly what the most appropriate way of getting their problem sorted out is. So I think as a system, there's probably a potential productivity gain in trying to work on how we make the system more understandable, easier to navigate. The second point I wanted to make was really going back to that fuller stock take that Chris talked about. It's a very significant piece of work, and what it describes is that general practice isn't one thing, and it's best, what we need to do is try and make it clear to people there are different streams of activity which need slightly different approaches. At the moment, everything is focused on, everything is urgent. Everybody phones up on Monday morning at 8:30 and tries to get any slot with anybody, and everybody talks about general practice. And what we're trying to do is break it up and say that there are different elements of this. There is the whole prevention piece, which is our vaccination programs. Some of our, we talked about diabetes. It's picking up and diagnosing and trying to intervene earlier on lots of things that haven't yet become health problems but have the potential to. There's the same-day urgent access piece, which is about, you've got an immediate problem and needs sorting out. We've got the bit that is particularly being eroded is the complex patients, which is where you need continuity of care. You need ideally to be able to see the same probably GP every time you go. We know that patients who see the same GP are 25% more or less likely to end up in A&E or in a hospital admission. and that's being severely eroded because everything is being pointed at urgency. And so we need to try and roll back, break the workflow up in the way that the fuller stock take suggests, with slightly different models of access. And so for the urgent same-day access piece, yes, making that available, you know, in the evenings, at the weekends, making it clear to people how to access that will help everybody, I think.
Chris.
Thank you, Chair. And to the point that Councillor Wilcox makes about workforce, I think one of the learnings we had from COVID, certainly in the acute and community services, was addressing immediate workforce challenges. And one of the solutions to that was to work with colleagues who might be able to return on a kind of retire and return basis. That logic is now being extended to other parts of our NHS, including general practice. As I say, traditionally practices have worked kind of as individual entities, and part of the development of PCNs now is that we're able to bring a bit more cohesion. So that concept of retire and return that was successful during COVID for acute and community services is now being actively explored and will benefit the point that Councillor Wilcox makes.
Thanks. Keith, briefly.
Yes, Councillor Flunder, but never mind. Yeah, I'm glad to hear about the retained. I'm glad to hear about the retained workforce. I think that's something that is something that's worth, you know, developing even further. And my comment really wasn't about what's been done. It's about going into the future, about trying to get more access into the evenings and weekends, and trying to improve the service and to try and make sure that people can get access to those services that they need. Hopefully when they can access them, so they don't become fully ill, and therefore, you know, both economically and in terms of the NHS escalate to a higher level. And certainly, again, back to the children's thing, which you didn't answer, about the idea of children getting more access to flu jabs to try and reduce what's happening in schools at the moment as well. Thank you.
I'm sure that some of Keith's thoughts will be factored into the ICS plan that we talked about coming back to committee between now and March. Just one thing off the back of what Keith's talking about. I noticed there is lots of reference in these papers to general practice. And to me, general practice sort of evokes the idea of seeing a doctor. And when you talk about 25% of appointments could be seen by another party, presumably within primary care, surely more could be done to help people see the difference between primary care and GPs.
Yes, is the simple answer. I mean, I think this is one of the key things we need to communicate with our population, is that that first contact, and increasingly we'll try and streamline that. So we've got a program that's just started for winter called 111 First. We're trying to get people to phone 111, who will signpost people to the correct place. If they phone general practice, we need them to have that initial conversation with our reception staff to discuss the problem and say, how can I best get this sorted out? As we have a more complex workforce structure, we need to be able to help patients arrive in the right place first time. And so the communications will be, and we have a communications plan, but I think we generally need to try and we need to find a new description, because the easy description is booking an appointment with your GP, which everybody uses, and I sit in meetings and just clock what people's language are, and everybody talks about booking an appointment with a GP. 44% of appointments are with a GP, the remainder are with that wider workforce, and we just need a better way of communicating that, and we need to describe to patients why it is better for them to use 111 and use the online digital tools, or to speak to their GP receptionist about how can I get this problem best resolved. It's not just in primary care. I mean, it's not just in general practice, as you say. It's in the much broader primary care, and we have a very successful pharmacy scheme at the moment, which Staffordshire is one of the highest users in the country in terms of our access to that. We've got lots of other resources, but we just need to have that conversation with the public and get away from that language of booking an appointment with your GP. We need to have an easier way of saying, we want you to have a conversation with us about how best to resolve your problem, and then we will try and route you to the fastest, most convenient place to get that resolved. Again, my colleagues see it, and I talk about I see it in surgery, the number of times people are skimming like a stone with one problem between different services trying to get it resolved. It's really difficult for patients. It's a poor patient experience. It consumes our resources. And if we could make it work better, we would probably go a long way to solving the problem. I don't think there's a lack of capacity in the system so much as we're not using what available capacity we have to best endeavour. And I think that needs to be part of our, well, will be part of our strategy.
Thank you, Paddy. And obviously it's very frustrating for the individual involved because they have to keep telling their story so many different times. So that's useful. Chris.
And just on that broader point, I mean, Paddy alluded to this earlier in response to an earlier question about sometimes some services are commissioned regionally, sometimes some services are commissioned locally. From the 1st of April, the ICB will have delegated responsibility for what's called POD services, so that's pharmacy, ophthalmology and dentistry. So they're currently commissioned on a regional basis through colleagues at NHS England. That responsibility will come to the ICB from April. So our ability to perhaps have more cohesion and coordination across those various different services, particularly between general practice and pharmacies, will be enhanced as we look forward.
Useful, thank you, Chris, because Councillor Atkins will be very pleased that we'll be able to scrutinise dentistry at a local level come when those move in April, which is something we've been promising her for thick end of a year and a half. Anne Edgeler.
Thank you very much, Chairman, and thank you for your presentations and everything, Paddy and Chris. My question is, and I don't think there's an easy answer to this, I mean, the frustration that patients feel when they've got to ring at 8 o'clock to book an appointment, and they ring and they ring and they ring, and by the time they get through, their mental health has gone sky high. You know, so how you can solve that, I do not know, but, you know, that is one major problem. But my question also is, you know, moving forward, how are you recruiting doctors from overseas, actually, because I found it quite interesting. Only in the council building last week, I think it was, we got one doctor. He'd just been sworn as a British citizen. He was a doctor from overseas in Nigeria, and Paddy will know which surgery is at. And also there was another lady with him, and she was applying for British citizenship, and she was a doctor from Nigeria. So I thought it very, very interesting, you know, as to how you're recruiting from overseas and how is that moving forward. But and can I just say, Chairman, so members of the committee, if you're not a member of your patient participation group at your local surgery, please get on board with it, because it's interesting to see what people at the surgery and that are saying. So if you're not a member, please get on board with it. Thank you.
Paddy, we're with you.
So the 8 o'clock phone situation, I absolutely get the frustration, and as much as patients are frustrated, our staff are frustrated. You know, we get this huge surge in the morning, and it feels like we're trying to fit a quart into a pint pot. But I don't think we are. I mean, in my previous answer, I said, you know, I'm not so sure it's capacity. It's the fact that over several years, we've raised this issue of almost everything is urgent. Now, I know patients are used to shopping on Amazon 24/7, and culture has changed. But actually, when, you know, if we go back to the fuller stock take, everything is not the same. We've got 4 core roles in general practice, and we need to try and separate them out a little better. I think we're not as organised as we should be in terms of describing those different flows and the different workforce models and the different priorities. So, you know, if I'm a frail elderly patient with a complex condition, I probably do want to be able to see the same experienced GP who can untangle that and have some conversations with me about what level of care and what is reasonable and unreasonable. And that sort of personalised complex care that were provided by continuity of care is quite different from when you pick up your child from nursery at 3 in the afternoon and they've got a fever and you're giving them a dose of Calpol, and at the tea time they're no better and you need to see somebody competent, or you need a conversation and perhaps to see somebody competent. So we're trying to provide one model of care for actually what is probably 4 different models of care that we need. And I think part of our strategy is to try and tease those apart more clearly and be more explicit with patients around why we're separating them. There's far too much emphasis on the urgency. I mean, it's only a proportion of general practice work that is urgent, and it needs to be easy to access it. A lot of it's based on continuity, and then there's a whole raft around long-term conditions. And you asked earlier about diabetes. I mean, diabetes consumes 10% of the NHS budget, and if you look at the rates of diabetes driven, unfortunately, by the obesity epidemic in the Western world, the rates are going to rise rapidly. It's going to put extreme pressure on health services and every other service. And we need different approaches to each of these, and we need to be clearer with patients. And I think we need to roll back from this idea that everything is urgent and everybody has to phone up at 8:30 for every problem. We need to make it, we need to make slightly different models of care for those 4 different fuller streams, and then we've got a chance of actually making the experience of getting an appointment when it is urgent a lot better. On recruiting, so we call them IMGs, International Medical Graduates, and one of the joys of general practice is, and medicine actually, is that huge diverse workforce. So, and over the years, I've been a trainer of GPs. I was a trainer for 20 years, and see people from all over the globe coming into the UK. The UK is a less international medical graduates. If you're moving from overseas, why would you choose the UK over Australia, Canada, the US, the Emirates? Lots of other places in the world are probably more attractive than the UK is now as a working experience. We have a high proportion of our GP trainees in Staffordshire are IMGs. There's a phenomenon where as you move north in the country, you get a higher proportion of international medical graduates to UK trained graduates. There's been a reduction in people coming out of medical school choosing general practice as a career choice. And this is driven by the experience of working in general practice. It's not deemed to be a great place to work at the moment. Excessive bureaucracy, excessive hours. It's becoming more difficult. Our issue with the international medical graduates is we train a lot of them. I think I had a meeting last week with our 2 workforce leads for general practice. And I think in North Staffordshire they had 23 or 26 people had come off the local training scheme. Not one of them chose to take a job in North Staffordshire. Our IMGs have moved from outside the UK into Staffordshire to do their training. They're quite happy to get on a train to Manchester, Birmingham, London, and work elsewhere. Increasingly, they're going to Canada. So we're training them when they're coming out of our training schemes and going to Canada. Immediately afterwards, I've had 2 trainees who've moved to Canada. We're not an attractive proposition at the moment working in the NHS. We're not a particularly attractive proposition in working in general practice. And the trainees are preferring urban centres to more rural communities. So we're particularly pressurised in some of our in Staffordshire, and I think we have the lowest increase in training numbers in the region. I haven't got official figures for it, but I think we lose quite a high proportion of our people coming out of training schemes for the reasons I've just mentioned. So there are some of this isn't in our gift. Some the training posts are recruited to regionally. There are national conversations going on around some of the elements of this and how you can golden hellos and lots of different schemes to keep people local after they've trained and entice them to stay for 2 or 3 years until they've put down some roots. But it's really challenging, and I think Staffordshire is particularly challenging. Well, Staffordshire and Shropshire, I think, are particularly challenging environments for recruiting and retaining new trainees. But they're great to work with. I mean, the Nigerians are great.
Thank you for that. That's quite worrying, actually. We're doing the training and then they're flying the wings and off they go. So I don't know how we solve that, but I'll leave that with you, Buddy. Thank you.
Thank you. Janice. We're with you.
Yeah, thank you. I've tried to sort of order my thoughts still from obviously what people have already discussed, but they'll come across in an order. By all means, come back to me if they don't make sense. First of all, I was trying to gauge the participation in some of the data that you put through. I think you'd mentioned there's about 143, 144 providers. I didn't count all of them on those charts, but I just wanted to know, were they all included? Was participation pretty good, I'd say, on those, or could it still be better? And then the next part, we've looked at the key drivers, and patients, I think, say, the comment is patients generally want to see the GP, and you've mentioned signposting. And then went on to suggest people going to 111, and that is the preferred first port of call, if I'm understanding you correctly, as opposed to the GP's receptionist. Is 111 resourced appropriately to deal with the likely demand that is inevitable as we go through into the winter season more so? And then that sort of picks up the consistency side a little bit, but also we can see the consistency, what's already been discussed between the telephone access, and you also mentioned the online digital tools. We've had a discussion previously about the apps that are available, and I think anybody who wanted to go anywhere once restrictions started to be lifted all ended up with the NHS app. I still cannot make an appointment with anybody in my surgery through the app, and consequently 4 phone calls later, I only needed to see the nurse. I knew specifically it was to do with the nurse because it was the letter that I get every 3 to 4 years telling me I need to go over and have my check. That I could have just done quite simply on there. So again, it's that if we're not getting consistency between people being able to deal with phone calls, how can we look and try and achieve the consistency between people being able to access online, which I think is a good thing, and it frees up then the telephone service for those who can't use the online ones. So a few questions there, all put together. By all means, come back if you need any clarifications. Thank you.
Paddy.
On the participation, if you look closely at those slides, what you'll see is we couldn't get all the names on the legend, and so I think every other column has got a practice name to it. We've got the data on all of the practices, but there's only half the names on there just because they won't fit. And I think the point we were trying to make, not but that we were particularly trying to sort of identify practices on that, because what we really want to do is just show the level of variability, which particularly for the access thing is not what we would want. You know, we've got practices getting nearly 90% approval for their telephone access, and then we've got practices with 20% or less. So the point is the variability, but we've got data on all of the practices, and a lot of this is now is openly available. NHS Digital last week made practice appointment data available, and I think it's going to appear in the press probably this week in terms of the appointments and the appointment types. In terms of the route in, I mean, I've said several times that I think it's really complex. You know, and there isn't probably going to be one route into GP appointments. There'll be multiple routes, but it needs to be clear, I think, to patients, and we need to do a lot of comms around, you know, what those routes are. So, as I say, there's a campaign which is sort of set off this week, particularly before winter, around 111 first, because there are increasing resources both to the online version of 111, but also to the telephone version of 111 to try and increasingly make it a tool for patients to navigate the system and to end up in the right place. And yes, resources go into that. That whole program is really managed by our ICS urgent and emergency care portfolio or program, and they're probably better, and some of my colleagues are better speaking to 111 than I am. So it won't supplant general practice at the moment. I mean, GP surgeries and the receptionists know a lot of our patients very well and know how to manage them. And also know when to escalate them. You know, patients who are more vulnerable, patients who have weakened immune systems, people who have complex mental health problems. The best navigation you can get is probably from your GP surgery. It's just that we need to make the whole offer, I think, less complex and clear to patients. The telephone versus digital versus online booking appointments, I think is challenging because, again, there isn't a single offer to patients, and it's certainly not seamless. As I said, because of our diverse workforce, we increasingly need to signpost patients. And so direct booking into appointments presupposes that patients know who they need to see, and they don't always know. Sometimes they do. Sometimes it's routine stuff that they know exactly who and what they need to see, and making that sort of direct booking more effective would be one of our aims. But it is that sort of signposting bit that we need to get right, and trying to make it all seamless. There are multiple tools out there, and they don't all work well together. We're increasingly trying to do what's called online consultations, where actually you fill in a sheet of information and pose the question you want solving that goes into your GP surgery. We have lots of those coming into us every day. It gives us a quick idea of what the problem is, and we can do our signposting on that digital tool. Some people, because of their IT or their skills, may not be able to use that. They can use the phone. But if we can try and route as much away from the telephone line, I think we can start to get away from that 8:30 experience or 8 o'clock experience in the morning of blocked phone lines. So there will be multiple routes in. It's just at the moment there are too many tools. They don't all work seamlessly together. And so one of our programs around primary care digital innovation is to try and improve access using a variety of different means, and that'll be direct booking, it'll be online signposting, it'll be on phone signposting.
Thank you. Janice, do you want to come back?
Briefly, yeah, if I may. Yeah, so thank you for the information for the 111 and the resource that's going into there. And as far as practicality of patients who are getting through and they're using that as the first point of call, is it then likely to be the case that they're then directed back to their GP surgery, but it's a filtering as to, okay, well, you might want to go and see your local pharmacist, or you may need something more serious than that. But will they then need to go through all of that process and all of that explanation again with whoever they're then referred on to? Is there any linked up sort of connections there? Thank you.
Yes and no. I mean, so if you look at, and again, some of my colleagues are better placed to give you a sort of detailed discussion of 111 and where it's going. But if you look at what we call dispositions, sort of what comes out of 111, that there's a range of dispositions. So some people will be directed to A&E. Some people will have an ambulance sent to them if it's something urgent. Some patients will be directed back to general practice, and we have a system now where every general practice has a number of appointments every day available for 111 to directly book into. So I see in my appointment screen on a Monday some 111 appointments appearing where they've been directly booked, and we'll make contact with the patient and sort them out or see them as appropriate. And yes, they will be directed or signposted from 111 to the whole range of services that are available. So that's building. As I say, there's an online platform which does something similar, and then there's this sort of voice version of 111, and they can obviously medically escalate calls from a call handler to a 111 doctor if they need more complex conversations. But there's the whole program about making 111 one of the effective signposting routes for the system.
Thank you, Paddy. Thank you, Janice. Just two other things related to that. One is that we will, after this meeting, circulate details of where you can find practice data, because it has been published by NHS Digital, so we can circulate that. We didn't circulate in advance of the meeting because I had a fear that we would spend all of our time talking about individual practices rather than anything else. I also note Paddy's comment, which was that online and app booking is an aim, not a commitment, but maybe we'll come back to that in the future. Bernard Peters.
Thank you. Just to go back to the point you were making about changing the terminology, I want to see a GP. I think this is a good opportunity for you guys now to start engaging with the PPG in more depth. They're truly patient-focused, and those that are very active and taking it seriously will be more than happy to assist you with that message. So I would encourage that and hope that you'll take that forward.
Yeah, I mean, I've been to my district PPG meetings during the CCG time, and there's quite a lot of good practice out there. So we've seen co-produced leaflets between PPGs and their practices, which have worked really well, and we've circulated those to other practices. So you know, I think in terms of testing the language we use, you know, testing that with PPGs would, you know, is ideal really, and we need to test our communications with our customers to make sure what we think is being understood, or how can we change the language into something that is simpler for everybody and actually works. So I think, you know, we have a comms team who are, I mean, there's national comms around this, but I think also locally we need to work on the messaging and how best to disseminate that. And probably back to what Chris's point is, if we have 144 versions of this, it's really difficult because people speak to each other and they go to different practices, and we need some consistency around the language and some consistency about the messaging, so it builds and it's retained and people understand it. And I think that's part of our communications program.
Thank you, Chris.
Yeah, thank you, Chair. So it's actually building on what Paddy's response to the previous question, but I think it's relevant to the most recent question as well, is that the data that we've shared with you today is taken from the National GP Survey. So that has a particular response rate. So it's important information for us, information that we're happy to share, but it's by no means the only source of information that we draw on. So you referenced the National GP appointment data. So we will share that. That's GPAD, GPAD. So colleagues look out for that acronym when it comes through. But we also work with PPGs, and we've referenced a couple of times the importance of those, and we'd share that. We included in a pack an extract from the 360 work we do at individual practice level. And of course, we often have soft intelligence about some of the challenges that are out there. So we do draw on a range of information and kind of triangulate that to give us a bit more of a broader lens. To the previous point about 111, just to confirm that it is actually a commissioned service for Staffordshire and Stoke-on-Trent. So the ICB contracts that service for a provider called Vocare. And that does mean it's in scope of active contract monitoring, so things like volume, quality, some of the metrics around time to answer calls, etc., are all monitored on a monthly basis, and any issues raised between the ICB and the supplier in question. Thank you.
Thank you. Yeah, we've got the GPAD data. We'll circulate that ourselves rather than asking you to do that. Bernard, do you want to come back in any way? That's fine. Thank you. Let me go on to Thomas J.
Yeah, thank you very much. I'm just going to backtrack to quite a bit earlier on that Dr. Hannigan said. So sorry to single you out. Obviously, lots of what's been said makes total sense, but there's two bits. One, I think we should steer clear, or tread carefully at least, of blaming patients, because it is capacity. As a user, I believe at least it is capacity, and saying it's patients, I don't think is the right way to go. I haven't got lots of data to back that up, just personal experience. I've got two daughters born 7 years apart. If I go back to the first daughter when she was poorly, I could call the GP in the morning, maybe within 10 minutes get through, choose an appointment that day from a list of appointments. Now with the second daughter, an example, this week that's just gone by, I called at 8 o'clock, and I'm a normal person, right? I believe I'm a reasonable person. I do all the over-the-counter stuff, I do all the home remedies first, and only call the GP right in the third week. from 8 o'clock in the morning till 9:36 when I got through, and they said, no more appointments, you should have tried earlier, right? So I called 111. They said, okay, we've referred you back to your GP, but they've said they've got no appointments. So around this circle, they said, call back the next day. 3 days of doing that, got nowhere, so I called the out-of-hours service, 6:30 in the evening, and managed to get a Saturday appointment to see a GP. So the out-of-hours service was fine, but I don't believe that personally in my experience. That's not to do with me, that's capacity. And I compare one door to the other 7 years apart, it's definitely got worse. And I don't believe it's patience, it's capacity. And then the second point, the UK is a place that people want to come and work. I run an international recruitment firm. Some of the positions we recruit for are doctors, nurses, healthcare assistants, etc. And it is things like decision makers taking too long, GMC taking too long to put their test dates out, and then when they do, they don't give enough. Home Office saying they'll do a visa in 3 weeks, and it takes 3-4 months before they even reply. It's the whole system around it. It's not the UK being attractive. The UK is attractive. It's the whole system being slow around it. So just some comments, not necessarily to come back on, but I just want to tread carefully on those 2 points.
Thanks.
Absolutely. I will come back on certainly the first point, because I absolutely wouldn't blame the patients. I think the systems we offer are overly complex, and they are difficult for anybody, including me, to navigate. I did have to try and navigate it myself last year, and remarkably complicated to get simple things done. So I think trying to make access seamless, trying to separate the different streams of work that we're trying to deal with, and trying to get away from this sort of one size fits all, so that we better utilize our capacity. And as I said, we the number of patients that are having to make multiple calls, and some of these are actually booked time with these services, and have a time, a resource implication for each of the services they make contact. So getting people to the right place first time is definitely what we're trying to achieve. Yeah, more capacity would be great, but it doesn't look like that's coming anytime soon in terms of funding streams into the NHS in the current environment. So I think building more and asking people to work more and longer is not really tenable. What we need is better productivity, better efficiency, and trying to make the patient experience better. So if we can get people see the right professional first time, that will be better for patients, and it'll be better for us in terms of trying to manage that.
Thanks. Thomas? Do you want? Okay. Phil?
Thank you, Mr. Chairman. Paddy makes some good points about understanding illness and understanding who you want to see. So whenever these type of discussions, this scrutiny comes place, it always gets a little bit parochial, Mr. Chairman, because you'll always relate to your personal circumstances, and I'll try and put that on a broader picture. So I understand that there are a number of ways of getting in touch with the GP. For the 8 o'clock phone call, and I'm sure we've all experienced redial to 111, to booking an appointment online. And I think I'm sensible enough, as Thomas has just said, to understand the system, to understand what's best for me. So my personal thing was, I was quite poorly, and I was poorly for a number of days and knew I needed to see a doctor. So I just kept hitting the button at 8 o'clock, and eventually I saw a doctor. The reception responded exactly as she should have done, and I got fairly quick medical treatment, as Paddy described early on, when something was urgent. And when my knee hurt, and it hurt a lot, that didn't require anything urgent. So I went online and I booked it online for about 4 weeks in front, and I was quite comfortable with that. So I think what you've described, Paddy, is great. But, and this is where the scrutiny but comes in, because I've now tried to use the online system again to say, actually, this is not an urgent appointment, but I'd like to see a doctor or a medical practitioner, and there's no online bookings, there's nothing. So what it does, ring 111 or ring your surgery. So going back to Thomas's circle, so I'm happy to use the system, and I'm happy to understand the system. I have a level of intellect and understanding how to use it, but the reality is, even for me, who's comfortable that I don't need urgent medical care, just go straight back to the 8 o'clock appointment, which I wouldn't bother with, because I feel I'm wasting other people's time as well. So the challenge is, I agree, we need to have a number of ways of approaching it, but the challenge is that the systems need to be brought up to speed quickly, and there needs to be a number of non-urgent appointments, and these need to be available, and as far as I can see, they're not available. Thank you,
Thanks.
Mr. Chairman.
Paddy.
I don't disagree with the experience, because that's the noise we're hearing from everywhere. As I say, part of our strategy is to separate out streams of work, slightly different approaches to the what's needed in terms of workforce models. Do you need continuity from the same practitioner? Do you need a team approach from a multidisciplinary team? Do you need urgent care same day with a professional who can manage the scope of the problem presenting? So we need to try and sort of tease apart the workforce, and then and line up our so tease apart the different workflows, and then assign our workforce accordingly. The tools of how we access that, I've said several times, I think it's overly complex, and I absolutely see the difficulty in people knowing how to get to the right place, and I think that is one of the biggest challenges for us. I think the whole digital agenda in the NHS is behind the curve, really. I think most of us on our smartphones these days manage our banking, manage our travel booking, manage all sorts of services actually pretty slickly. The NHS is just way behind that. It's not easy. Whilst NHS app usage has rocketed on the back of COVID, actually what's available through it is still rudimentary, and it is not that experience which most other industries are managing to offer. So I think there is a real need for a really strong push for those digital tools that will not be everything, because there will still be people who will need to use the phone lines. But if we can get a significant amount of traffic off our phones, because people can get directly access to services they want to digitally, that will hopefully make a big inroad into the 8 o'clock rush.
Chris.
Yeah, I'd like to think that what Paddy and I have shared today shows that we're not complacent. We're not trying to paint a picture that everything is rosy. We absolutely accept that there are some real challenges in particularly access in terms of general practice. We've shared the data, and we've talked about some of the key drivers and the solutions, and I think we know what those solutions are, whether it be telephony, whether it be about resilience in the workforce, whether it be about digital innovations. I think the challenge is, how do we bring forward those solutions in a way that's got some cohesion and coordination about them? And I think, as we state in the last slide, the advent of the Fuller report is a significant moment, because it gives us 4 really clear areas that we will be able to kind of coalesce around and work together with general practice to bring forward those solutions that I think we know are the right ones. It's just difficulty getting the traction behind them.
Thank you. Phil, do you want to come back?
Yeah, just for a second. I think we're in agreement in a sense that the NHS app, it's really not very good, is one of the nicest things I could say about it. As far as going on it, ordering a repeat prescription is fantastic. I mean, what a great system that is. Pop, repeat prescription, absolutely great. Anything else, I've absolutely no idea what else the NHS app does. I genuinely don't, and excuse my ignorance if you're going to give me a list of things it does wonderfully. But apart from doing that, so I genuinely think digital is the way forward. I think there's a lot of us, there's a huge amount of us can work digital, and that releases time off for people that can't. But the NHS app is not very good. That's my technical appraisal of it.
Thank you, Phil. I just wanted to sort of try and frame this, Paddy and Chris. I think in this day and age where you can get systems that work across the country, across the world, you know, what does Microsoft do after all? You know, it doesn't work just in a county like Staffordshire. You know, for the NHS not to have a standard way of working and a standard offer, to me is just completely barking mad. And every ICS is creating a new promise for customers when, frankly, I thought this was a national health service. And so frankly, I think we probably are on the wrong page on this one, unfortunately, because actually the centre should be doing more, and maybe the issue is actually addressing the issue with the GP contract. Maybe that's the issue that's really here, because in my view it's bizarre. We've got the best brains in Staffordshire working on something that actually they should be working on a national basis rather than a local basis. And I'm not making any political points. I'm just making a process point here, which frankly it just doesn't seem like a logical outcome in terms of where we are. I don't think Phil asked any supplementary questions, so I'm going to move on to Jill Hood and then guillotine the debate, because I also want to ask another question. So, Jill.
Okay, thank you, Chair. To Chris and Paddy, I have continued since the pandemic to volunteer, which means I take a copious amount of extremely elderly people to my local GPs, Stone Urban. We have a population of just 20,000 with only 2 doctors' surgeries. I sometimes almost fall on the floor with embarrassment and cringing at the gross breach of GDPR, which is every day of the week in a doctor's surgery. One doctor's surgery has a little microphone, so it's far easier to hear the intimate details of every patient who speaks to a receptionist. The other one, the patients have to shout through a screen. Name, date of birth, address. Can you tell me what it's in relation to? And I sit there listening to these people giving all these intimate details, and I just shake my head and think, if there's anyone sitting in that doctor's surgery, such as myself, who doesn't have an appointment, and believe me, it's very easy to go into a doctor's surgery wearing a mask. They don't know who you are. I'm quite often recognised and chat to people. You can hear every detail of these poor elderly people, and they're mostly elderly. There are quite a few vulnerable with special needs who willingly shout their information to the receptionist. For goodness sake, you know, is this common practice in every doctor's surgery throughout the land, where you have to, you know, bare your soul while everyone's listening? I just hope that perhaps there's a little bit of sympathy that can be considered for these people. I remember in one surgery there was a little sign that said, if you want to be treated in confidence, please go round to the other window. Well, there isn't another window now in either practice, and it really, really is gross. And I just wish that something could be done about it. Thank you, Chairman.
Paddy.
Not a good story. I mean, that sort of reception working is custom and practice in terms of what surgeries know they should be doing, and it's actually the sort of stuff that the CQC are really hot on. So that whole reception experience and how they manage people with hearing difficulties or anybody who needs to talk across reception is something that the CQC focus on. COVID's dented that quite badly because of that sort of feeling that you needed to protect people across a reception. And well, firstly, the fact that people weren't coming into reception at all for a period of time, but then that whole reception experience. So a lot of people who had, we'd taken out our reception window for just that reason, so that people didn't have to shout through glass. We had to put it back to stop people spreading viruses across the desk. Most practices have induction hearing loops, which I'm sorry to hear the story that everybody was broadcasting to everybody in the waiting room, but that's something we can pick up and make people aware of. But that sort of whole thing around, if you want to go somewhere else to deal with something in a more confidential manner, I would have thought most practices would have had something up to that effect. But that's the sort of stuff that CQC is very focused on. As I say, a lot of it has not worked as well with the COVID experience, but we're drawing out of that now, and certainly a lot of our guidance we're giving practices is around how they can sort of normalise the experience across reception. Again, as much as we do a lot of this stuff digitally, I remember when we put in the check-in screen in our reception, we cut down the need for people to shout their name and any of the details across reception because they were all checking in electronically. So there are ways to mitigate this, and that's certainly something that we can take back and use with the primary care team in terms of just heightening people's awareness of that. GDPR and the whole data security thing is something that practices are normally very hot on. So again, it's a disappointing story.
Chris.
Yeah, so I mean, it is a disappointing story, and the practices are absolutely responsible for their own GDPR, and they should be taking appropriate steps in the way that Paddy's described. Colleagues probably won't be surprised to hear that we have a communications and engagement mechanism across all GP practices. So just listening to that particular story, we will take the time to ensure that we include in the next update a reminder about GDPR and the steps that practices need to be taking to protect that.
Thanks. Jill? Okay, last question on this, you'll be pleased to know. I just wanted to move more towards estate. Clearly there's a variety of support people within primary care and within primary care practices. And I wonder whether there's been much analysis done of the limiting factors within each practice. Because I wonder how much the estate is fit for purpose for the 21st century and post-COVID world. I'm mindful that there are practices who could take in dietitians and, physiotherapists and all sorts of other people. There is funding for them to do so, but their estates are very 19th century. And I don't mean sort of Dickensian, I mean that they are constrained in terms of size because they were built for a time when there wasn't necessarily these multidisciplinary teams. So has there been an audit of estate, and how do you see the GP's investment in their estate?
So there is an audit of estate that's been going on for a couple of years. We've got a team which covers estates, and we've brought in some and enhanced that team over the last couple of years, and they've been working their way across the entire GP estate to give us a really clear view of where we are. It is challenging, 144 GP practices. Most of those practices, or many of those practices, will be privately owned by the GPs. Albeit that the NHS reimburses that under a reimbursement scheme and therefore has some say in terms of the type of estate and and some of the factors within it. But as you can imagine, the capital budget for the ICS is challenged, and improving the estate would be a significant challenge. I think there's a broader piece about many of the issues we've discussed that today. I mean, 70% of our consultations are face-to-face, 30% of them are remote. There is something about how practices might not always require their staff to be working from within the GP surgery. There's an efficiency there. We've had a conversation earlier around the fact that traditionally general practice is open from 8 a.m. till 6:30 p.m. 5 days a week. So there's a significant amount of estate underutilization in evenings and weekends. We've talked about how practices are working more collegiately as PCNs or as federations, and how they can actually utilize estate across several practices. And then as an ICS, we need a conversation around how we make best use of all of our estate, and not necessarily seeing the estate as solely for the use of one organisation. So I think there's a number of approaches we need to take to this. you know, it would be nice to say we're going to go out and modernise and build a lot more, but, you know, realistically we're not. But I think there's a lot of ways that we can mitigate the estates issue. I think there needs to be quite a lot of rethinking about how we provide some of these services, and the assumption that every person needs their own desk in their own room in their own building is probably not the way forward. And I think we need to be more agile in the way that we work, and I think we need to be more collegiate in the way we work. Now, clearly that there's issues around access, and we've got a significant rural population across Staffordshire who will need services that are convenient to them, but equally there are efficiencies we can make elsewhere.
Thank you. Chris.
Yeah, I think it's probably worth saying that we do recognise there is quite a degree of variability in the quality of the estate into the fabric and the infrastructure that's wrapped around those. I think if we produced a graph that showed that variability, would be very similar to some of the charts we've shared today in terms of experience and access. Actually, we'd have some that are pretty good. We'd have some that are pretty poor. Actually, I think we could probably all think of particular instances where some services are delivered out of porter cabins, for example, which clearly isn't where we would want to be. So as Paddy says, there is an ICB-wide team that look at primary care estate. They link into the wider estates review. So just two broader points on that. One is in terms of use of public sector estate. There is programmes of work across local authorities, across the NHS, across GP practices about how we make best use of that. Very recent example, the ICB has just taken some rooms in Trent Meadows GP practice to offer a little bit of a hub for ICB staff who, generally speaking, would work from home but may from time to time need to come together. We've been able to source that estate from within existing GP practice capacity. And then there's a broader link to the sustainability agenda. So I'm sure colleagues will be aware the NHS has a requirement to be net carbon zero by 2045, and obviously the use of estate and GP estate within that is a central component of that. So I think no one's going to pretend that we don't have some real variability, but there are plans in place.
Thank you, Chris. So I think on that basis, that brings this item to a close. So I think that a committee is broadly supportive of the work that's going on, but obviously remain concerned because of the concerns on access, but keen to see the plan and accept that this is not a simple, easy issue to resolve. And not helped by recruitment issues. So I think, are we happy with that as a holding position? Yes, I'm seeing plenty of nods. So on that basis, Paddy, Chris, Tracy, can I thank you for your involvement this morning and the information and plans that you brought with us, and maybe we can just see the plan when you've built that in advance of the ICS signing that off, please. You're welcome to stay with us, you're welcome to go, but otherwise, thank you for your involvement this morning.
Thank you, Chair. Thank you all.
So that brings me on to item number 7, which is District and Borough Health Scrutiny activity. Canuck.
Thank you. I just wanted to let you know what was going on in Cannock Chase at the moment. We've been investing heavily in efforts to address the wider determinants and district health inequalities and to promote health and well-being. The Council has incorporated key milestones within its priority delivery with its health and all policies, health and well-being strategy and our health improvement programme and the app for Cannock Chase Can. The Council has allocated funding for a new Health Improvement Officer post, which is responsible for taking the Council's agenda on health in all policies and development of a health and wellbeing strategy. The Council has allocated funding for a 5-year health improvement programme under the umbrella of the Cannock Chase Can app as well. Members at the Council have requested details of progress on key issues aimed at addressing health inequalities within the district. In particular, with the implementation of health in all policy, development of the health and wellbeing strategy, progress within the development and using of the Cannock Chase Can app, inspiring healthy lifestyles and how IHL can contribute to the district's wellbeing, through the healthy activities. Prior to the former health scrutiny items, member workshops have been delivered in which members were updated on progress with the Council's health and wellbeing strategy. Key information was given to members on wider determinants within the district, and members were asked their views on a proposal health and wellbeing strategy, which was based on the Marmot principles and linking with these the Council's corporate priorities. Thank you.
Thank you, and thank you also for the very thorough and detailed report and touches on much of what we talked about in the first hour and a half of the committee. Two comments, if I may. First of all, given I know the funding constraints within Cannock Chase District Council's area, actually funding a new post, I think, is a very big statement of intent. And if anyone needs to understand the detail of what I've just referenced, maybe just pull Cannock's budget pack. And the second one is, I wonder whether there is some value in adding some of your information, like as a case study, within the council's SharePoint site, so that it can be referenced by other councils if they felt they could pick that up and use it, accepting that, you know, we all are slightly different.
If I can, the Cannock Chase CAN app, I believe, is being worked with Stafford Borough as well as a model to be rolled out as well across the area. So that might work for here as well.
You learn something every day, don't you? Even as the Deputy Leader of Stafford. Right. Moving on, does anyone else want to add anything to this item? I think it would be useful maybe to suggest the same for Tamworth in terms of picking up some of their stuff and maybe putting it on the SharePoint site, and we'll take that away with us as well. And we can start building that as a resource for district and borough colleagues. Okay, not wanting to prolong things because the witching hour is nearly upon us. Item 8 is the committee agenda going forwards. Does anyone want to add anything? Charlotte Atkins.
Can I, as you mentioned earlier, can I just clarify what is happening with dentistry? Because I see that the March meeting talks about children's dentistry and fluoridation and orthodontic access. The issue, certainly orthodontic access is an issue, but the main issue is adult access to dentistry, because by and large, dentists will treat children, but will not treat their parents, or will not give them, will not take them on within NHS dentistry if they've been taken off another list or they've not had a dentist. Anyone looking for a dentist, certainly in North Staffordshire, will find it very difficult. Then I also see that further down it talks about dentistry transfer to ICS commissioning and talking about April 2023. So can I clarify exactly what we are doing on dentistry to make sure that we're not missing the key issues here?
Really good question, thank you. The first point worth making is we need to make sure we scrutinise something which is a policy which is owned by the Commissioner. So the timing of it will largely depend on whether there is a plan in place for the March meeting or whether it's then the meeting after March, which is, I think, June, is it? So it'll be one or the other, but I can't say exactly which, but there is no point in scrutinising something in theory rather than in practical reality. And to pick up your first point, maybe Debs can give us some enlightenment.
Is that in relation to the timing of the children's item?
Children. I mean, we don't want to focus on children when that's not the issue.
Thank you, Councillor Atkins. Initially, when we talked about this in the work programme discussion way back in June 2021, 22, sorry, we talked about children as a potential issue. However, it is yet to be scoped. So when it comes through to the meeting in March or June, there will be a scoping of the item to see what
it certainly wasn't children that we were focusing on. That may have been an issue, but the main issue is adults' access to NHS dentistry anywhere within North Staffordshire. If you're dropped from a dentist, you cannot get an NHS dentist anywhere in North Staffordshire, from what I'm hearing.
I heard the point loud and clear, and may I suggest that we try and frame a question, which will then circulate around committee during January to make sure that when it comes in front of us in either March or June, that we are answering the question. Because equally, I don't particularly want a discussion that's so far-ranging that we don't actually get underneath the surface of the subject. Anything further on that? Sorry, Janice.
Yeah, just a quick one from the original conversation that we had for the first Women's Health National Strategy. The list that was developed was passed over at the beginning of October via, I think, Director of Communications and Services to the Chief Medical Officer and Chief Nursing Officer, and we're still waiting for responses of those. So for those lovely ladies who were involved in those first discussions when the list was put together, the essence now is to put a Staffordshire focus and hopefully a list of priorities of where our attention is to be best served. So as soon as I get some responses and updates, then I will be in touch with those who was first involved. Thank you, Chair.
Thank you, Janice. Thanks for the update. And I notice it wasn't on there, but we'll make sure it's certainly on there for a regular update. And on that basis, let me bring to today's meeting to a close. I want to wish committee a very Merry Christmas. Please enjoy what the season has to offer and don't overindulge all the time or too often. Please do get some downtime, refresh the very grey cells, and come back raring to go in the new year. There is, after all, work to be done on physical health, mental health and public health if we are to make a difference for those in our communities in Staffordshire. Have a good 2023. Thank you.